So I think the best part about this update, apart from the fact that it's going to be an academic feast for the next 2 days, is that we've actually gotten out of our Zoom conference pajamas and we're here in person and we get to meet everyone after two whole years or probably even more. So with that, and I'd also like to welcome our virtual audience and we look forward to your questions and comments on the chat box as well. So with no further ado, I'd like to first call Dr. Suman sir to tell us a little bit about the agenda for the program.
Hi everyone, I'm sure Sujata has really touched a chord in all of us. Everyone has really gone into a withdrawal syndrome. I hope we can continue like this further unhindered. And so it's really a great pleasure to welcome all of you here in person as well as those guys who have joined online. And I'm sure we'll have a good academic feast with really good academic students here. We have all assembled in Pune after a long time. And a brief first, because actually I'm filling in for the CIDS president, V. Ram Subramanian. He will join us in the evening. And Dr. Priscilla Rupani, who's the secretary currently. She's also busy, but she'll be joining after some time. So all of you know about CIDS, Clinical Infectious Disease Society, and we have recently made a HIV subcommittee. So those people who are more interested, I'm sure everyone is, but some of us, about 5 or 6 of us, have come together to make this subcommittee, and we thought under the pages of that subcommittee we'll have this first meeting. And with that, again, I'll pass on to Sujata, who is the Master of Ceremonies, to tell us about the program. And we told me already about the chat box. And
yes.
Okay, fine.
Thank you, sir. So as always, prevention is better than cure. So we will start our program with our talk on PEP and PrEP, for which I would like to invite Dr. Rajiv Karthik, Associate Professor of Infectious Diseases at CMC Bangalore, to the stage.
Yeah. Okay, a very good afternoon to all of you. It's been 2 years, but I think it's worth the wait. We've all been on Zoom platforms. Finally, to stand in front of an audience and give a talk. It's like, playing a test match after 2 years. To the opening batsman, you don't know what to expect. So here goes. So my talk for the next half an hour or so is going to be on 2 very important concepts in HIV medicine, and that is prevention, and we're going to be talking about both pre and post-exposure prophylaxis. Okay, so I started with talking about pre-exposure prophylaxis, and what I'm going to do is talk a little bit about introduction, what are some of the early studies and rationale in using PrEP, and sort of guide you through what evidence we have over the last several years, what has changed over the last few years, what are the current recommendations, and what are the current options, and what are some of the ways that we could move forwards. Next. So we know that one of the major issues with HIV is actually prevention. And there have been several challenges in trying to prevent this infection from happening. And there are two main targets which we can use to prevent the infection. One is to prevent transmission from those who are already positive. And the second intervention is to actually prevent acquisition of infection among those who are negative. So for prevention of transmission from those who are already positive, we know that the most important player in that is actually treatment of the patient with HIV. And we know clearly that somebody who has an undetectable viral load is not going to transmit the virus. But what about people who are negative and who are at risk? What are some of the strategies that we can use to actually prevent them from getting the infection? If you look at these strategies, there are two main kinds of strategies. One are behavioral strategies, and the other are biomedical strategies. And PrEP and PEP both come under biomedical strategies. Okay, so PrEP essentially is a strategy which is used in individuals who are at extreme high risk of acquisition of HIV. And there are certain populations who have this high risk. And predominantly these are MSMs, transgenders, IV drug users, and female commercial sex workers. These are the populations that have the highest risk of acquisition of HIV. So this pre-exposure prophylaxis is not really a new concept, and we know we use it in rabies, we use it in other infectious diseases. So this concept of prophylaxing and preventing an infection from happening is not really a new concept to us. Next. So where did this initially originate from? And this actually originated from some animal studies where they actually used different drugs. And if you can see on the slides, you will see the percentage of uninfected animals using both either tenofovir, either emtricitabine, or a combination of both of these. And you will actually see that with both drugs on board, high dose tenofovir and emtricitabine, the number of animals that remain uninfected was very, very high. So this concept in the early 2000s came from actually animal studies. Next. So when we choose a drug for PrEP, remember we're giving this to somebody who is not infected and asking them to take it on a regular basis. What are some of the characteristics or attributes that we would want? We would want the drug to be very tolerable. You don't want a drug with a lot of side effects that you're asking somebody to take. So tolerability, low toxicity, it should allow once a day dosing or even less frequent dosing, something like that. That would be ideal. You want adequate drug concentrations in both the blood and in the tissues, especially in the mucosa of the genital and rectal mucosa and in the body fluids. And you need to have it demonstrable in and clinically efficacious in both animal and human studies. So these are some of the drugs, these are some of the attributes of the drug that we would want when we are choosing a drug for PrEP. Next. So this is one of the earliest studies that we have on PrEP, and it's the iPrEP study. And it was a multinational study looking at about 2,500 MSMs and transgender individuals who had high-risk sexual behavior. And basically, they gave one group placebo, and the other group, they gave a combination of tenofovir and emtricitabine. Next. So if you look at this graph, you think that there's not much of significance in the differences. And actually, if you look at the entire study, there was about a 44% reduction in the efficacy between placebo and tenofovir. And at the outset, this may not look very, very impressive. But what they also looked at in the study was, next, they looked at the effectiveness based on the patient's adherence. So if somebody said, this is a self-reported adherence, and if they said that they had more than 90% adherence, actually the efficacy improved to 73%. And if the adherence was only about 50%, the efficacy was only 50%. So very clearly showed that if somebody was taking this pill, it would actually work. So they went one step ahead and actually checked drug levels. Next. And if you see the bottom half, you will see that even among those who were taking the drug, there were 33 new infections in whom the drug was not detectable. So even though they were saying that they're taking the drug, actually no drug could be found in their blood. So effectively, they were on no medication. But among those who were taking the medication and had drug levels, the number of new HIV infections was very less, only 3, and that amounted to a relative risk reduction of about 92%. So what did the study show us? One of the early studies, and what it showed us that if you can take the pills and if you take them regularly, pre-exposure prophylaxis is a very, very good tool in actually preventing HIV. The problem in these studies was that the adherence levels were very, very poor. Next. So basically what I said, no increased risk of adverse events, no cases of transmitted resistance, and lower number of sex partners and higher rates of condom use in both arms. So they did a modeling study, and what they showed was if you take the pill about 2 times in a week, the reduction was 76%. If you took it 4 times a week, it was 92%. And if you took your pill 7 days a week, your risk reduction was about 99%. Next. So these are all some of just showing you some of the different trials that were done in the early 2000s, between 2000 and 2015. The IPEC study was done predominantly in MSMs. Similar studies were the TDF2 and the partners PrEP study, which were done in heterosexual women. And that also showed about a 60 to 70% reduction in new cases of HIV if the drug was taken. However, some similar studies like the SEM-PrEP and the VOICE study actually did not show any difference. And this was attributed to very, very low levels of adherence. Next. So this is what I was talking to you about, was something called daily PrEP. That means you take the pill every day, and then you look at, down the line, you look at what is the risk of developing HIV-1 infection in somebody who's at high risk. Now, there were issues with this daily PrEP, concerns about long-term toxicity, concerns especially about adherence. People didn't want to be taking pills every day, especially when their risk may not be that much. Okay, so what they said was, if they're not having high-risk exposures more than 2 times a week, they may not need to take the pill every day. So this was what brought about the concept of on-demand PrEP. And what this means is that you take 2 pills of tenofovir and emtricitabine 2 to 24 hours before your exposure, and then you take another pill 24 hours after the initial pills, and then another pill. So totally 4 pills. Okay, so you only take these pills when you anticipate a high-risk exposure. Next. And this was the hypergay study, which actually compared daily PrEP versus on-demand PrEP to see whether there's any difference between these 2 strategies. Next. And you see that in both arms, both these strategies were very, very good. But what you can see is that in those who got placebo, the incidence was 6.6, and those who got tenofovir was only 0.91. And this really showed that it was a 86% reduction even in on-demand PrEP. Next. Okay, so comparing these 2 is the study which is the ANRS preventive study. It looked at people who are at high risk, who took daily PrEP versus on-demand PrEP, and there was an interim analysis done in 2018. There were no new infections in both arms. The final results were in May 2020, and there were only 3 infections in both arms. So very, very low incidence of infections, and it showed that either if you take it daily or if you're somebody who cannot be adherent and if you're able to take it on demand, the results are the same. The number of days of pill intake was actually half in the people who took it on demand. The average was about 15 per month. The other group, you'll be asking them to take it every day, which amounts to over 30 pills per day. So this is the pill burden, and the pill intake is much less, but almost the same results. Different strategies work for different people, but what this shows is that both these strategies work very well in this population. Next. So moving to another high-risk group, what about intravenous drug users? they are also high risk for developing HIV. And this is a study from Thailand which looked about 2,500 individuals who were IV drug users, and they put them on placebo versus tenofovir, and showed that the number of infections in the placebo group was 33 compared to 70 in those who had tenofovir, which is about a 69 to 70% reduction. So even in intravenous drug users, giving them pre-exposure prophylaxis with tenofovir really helps and reduces the number of incident HIV infections. Next. So I just sort of listed the 3 different studies. The first study is the IPREP study. The second is the partners PrEP study in heterosexual women, and the third is the IV drug user study. So 90% reduction, about 70% reduction in this people. Next. So we're talking about tenofovir and emtricitabine. What about other agents? Have other agents been studied? And basically, the only other agent that has been studied is actually tenofovir alafenamide, which is a newer molecule which is believed to have less renal toxicity and less bone toxicity over a long period of time. So combining TAF with emtricitabine has been looked at, and this is a large study that looked at again MSMs and transgender women. So this is not being studied in other populations. Only in MSMs has been studied. Very large number of individuals, and what it showed was next. Very similar results. Very high rates of protection. Some laboratory evidence of reduced GFR in the TDF group and reduced bone mineral density. But how clinically relevant is this? It's not very clear. And the costs involved with giving TAF plus emtricitabine would probably be far higher than giving TDF plus emtricitabine. So both these are options, and either of these can be used. Remember, this has only been studied in MSM, so this cannot be used in heterosexual women. Next. So over the last 5 to 7 years, we've heard a lot about the long-acting integrase inhibitors, particularly cabotegravir. And we know that that was being studied for both for therapy and for prevention. So these are the 2 large studies that have come out with regard to this use in individuals with who are at high risk for HIV. So on the left is a HPTN 083 study that looked at long-acting injectable cabotegravir versus tenofovir, oral tenofovir that was predominantly given in MSM men and transgender and women. And this was done in a multinational setting, South America, Africa. And the main aim here was to look at non-inferiority. So not to look at superiority, but non-inferiority. The second component of this was the HPTN 084, where they again used a long-acting injectable cabotegravir and oral tenofovir on the other side. But here they were trying to look at to see whether there is a superiority of this regimen versus the other regimen. And this was predominantly done in Africa in heterosexual women. Next. So this is what they did in this study, in the HPTN 083 and 084 studies. One of the groups got oral cabotegravir for 5 weeks and placebo. Subsequent to that, for the next almost 2 years, they got injectable cabotegravir, which was given every 8 weeks. Followed by, for the next 48 weeks, they were put on tenofovir and emtricitabine. The other group got placebo plus tenofovir plus placebo injection, followed by tenofovir. So they got only basically tenofovir. So the first group actually got a run-in with oral cabotegravir and then intramuscular every 8 weeks for about 2 years, and then the last part was both of them got tenofovir. Next. So this is the HPTN 083 study. If you look, the yellow or orange arm is the cabotegravir arm, and it shows the incidence is only 0.41 per 100% years versus 1.22 per 100% years. So this is a reduction of about 66% using a long-acting integrase inhibitor versus the standard of therapy, which was tenofovir plus emtricitabine. Next. Yeah, so this is just showing the difference between the two arms, and reduction was about 66%. So the HPKN 084 went on to look at basically heterosexual women, because not a lot of studies were done on how do we use PrEP in women. Most of the high-risk groups were thought to be MSMs, and studies were done on them. So this looked at heterosexual women in sub-Saharan Africa, and so that was the study population, almost 3,220 study sites. Next. So again, in the cabotegravir arm, there were only 4 infections versus 36 in the tenofovir group. So very, very significant reduction in the HIV incidence among those who were on the intramuscular cabotegravir group. And it was almost an 89% reduction in the risk of acquiring HIV infection. Next. So I just want to spend 2 minutes on this. This is a new initiative by WHO. It's called the dalpivirine vaginal ring. And what it does is it locally releases dalpivirine and is thought to prevent HIV infection. And there were several studies been going on for several years. The Aspire study, the Ring study. All these studies showed a very, very modest reduction. If you look at the sort of risk reduction in HIV, it's about 27%, 40%. Nothing that looks very impressive. But still, WHO has sort of advocated for this simply because these figures are in people who are very poorly adherent to this form of to any form of pre-exposure prophylaxis, be it oral pills or the vaginal ring. So the adherence levels are very, very low, and they did follow-up studies and showed that the adherence levels were improving. So that's why WHO has really advocated for this dalpivirine vaginal ring, using it as an additional tool for PrEP in women. Next. So these are the studies, some of the studies that are still going on. The REACH study is looking at adolescent girls, the Deliver study at pregnant women, and the Be Protected study in lactating women. So all these studies are still going on with regard to this vaginal ring. Next. So several questions arise when we talk about PrEP. Does PrEP increase the risk of other STIs? Okay, so that's a very important question. So we're giving somebody PrEP and we're telling them that you're going to be protected against HIV. The question is 2 questions. One, does it increase the risk of harmful behavior or high risk behavior? 2, does it increase the risk of other STIs, chlamydia, gonorrhea, syphilis? So when we give somebody PrEP and say you're protected, always the question is, would people engage in higher risk behavior and in acquiring other STIs? So this is a meta-analysis from 2018 that looked at a lot of studies that dealt with PrEP, and they found about 8 studies that reported STI prevalence, and there was an increase in rectal chlamydia and in gonorrhea among the patients who took PrEP. What about high-risk sexual behavior, not using condoms regularly? There were 13 studies which looked at 5,000 participants, and yes, there was an increased risk in high-risk behavior. So remember, PrEP is not just one-off. You give a pill and you tell them to go. It is a combination of things. You need to educate them about other factors that used to prevent transmission of diseases. Next. But the incidence of PrEP is not different between the type of treatment you use, whether you use an injectable agent or a oral agent. So it effectively remains the same, the incidence of STIs. Next. Okay, so this is just, I just put it as a summary for daily oral PrEP. Importantly, make sure you've ruled out HIV infection. So do a HIV test before you start somebody on PrEP. Make sure they don't have any features of acute HIV infection. So no fever, rash, lymphadenopathy going on. Make sure that their creatinine clearance is more than 30 because you're going to be using tenofovir. And they should not have any contraindication to the medication. So 2 oral regimens, TDF plus FTC, which is approved, and TAF plus FTC, which is approved only for MSMs. Next. So this is for cabotegravir. Again, document a negative HIV infection before starting PrEP. And there should be no signs of acute HIV infection and no contraindications for taking the medication. And this is usually given as intramuscular injections every 8 weeks. Next. So I've just tried to summarize what all we've talked about, and what I want to talk to you about in this slide is the road ahead. We've talked about several strategies for PrEP, but where do we go from here? The two things I want to talk to you about are broad neutralizing antibodies. We know that antibody therapy has come out for use in HIV, but it's not clear what would be their role in PrEP. So that is one of the things we can look forward to. There's several studies that are ongoing. The other drug is islatravir, is a new nucleoside reverse transcriptase inhibitor, which actually had shown a lot of promise. And about 13 studies were ongoing with regard to this drug, also for PrEP, also as implants. But unfortunately, in December, all studies had to be stopped because many of these patients showed a fall in their CD4 counts, which is not clear. So, right now we're still awaiting information on that. So this was one of the agents that was sort of thought of that could be an additional weapon when we talk about PrEP. So what we can look forward to is, results from those studies as well as from the use of monoclonal antibodies. Next. So these are some of the concerns and questions we have with PrEP. Poor adherence. How can we improve adherence? Forever we're hearing in the studies that the adherence rates are low, and if people adhere to therapy, PrEP works. But what can we do to actually increase this adherence? Concern for long-term toxicity will always be there, but multiple studies have shown that when PrEP is used with these drugs, the long-term toxicity is actually not there. So always this concern will be there. Concern for development of drug resistance. And this will always be a concern. Patients who develop HIV while taking PrEP, do they develop drug-resistant infections? And few studies have shown that yes, people do develop HIV resistance to ampicillin and resistance to tenofovir, but the numbers are very small, and the benefit we get with PrEP in preventing HIV is much larger than the few cases of drug resistance that we get. It does not protect against other STIs, and we need to be very, very careful about this, especially syphilis, chlamydia, gonorrhea. So these are things that we really need to concentrate on. And the cost of PrEP. In many of the countries, the cost of providing PrEP for a large number of people is actually very high. Next. So, just want to tell you that PrEP is not just about giving a pill. It's all of these things. Creating awareness. Sadly, in India, the government program still does not include PrEP. And small studies looking at people's awareness and attitude towards PrEP is that people don't perceive that they are at risk of developing HIV infection. So the awareness is not there. And unless we start with awareness, we're not going to get past, all of these things. So awareness, educating both patient populations and providers, providing PrEP, and actually ensuring adherence and retaining them in therapy. This is all what constitutes the entire concept of PrEP. And this WHO actually has come out with an app sometime in 2016, which actually is an implementation tool for health workers who are going to provide PrEP. So it has a series of steps that actually takes you through how you should start with educating your population, your providers, when you give them PrEP. Next. So, few more minutes. I'm just going to talk about PrEP. I promise you it's not as long as the last part. So, what is post-exposure prophylaxis? Post-exposure prophylaxis is very different. Post-exposure prophylaxis is when you already had the exposure. Okay, the exposure has occurred, the exposure is high risk, and you want to do something or intervene to actually prevent acquisition of the disease. The two main categories, there is occupational post-exposure prophylaxis, like all of us who work in the medical setting, and there is non-occupational post-exposure prophylaxis. It can either be sexual or it can be intravenous drug use. So what is the risk with all these bloodborne viruses? And actually the risk of transmission of bloodborne viruses is the highest with HPS-AG. And thankfully we have a vaccine for that. So HPS-AG, hepatitis E antigen positive, the risk is about 30%. For hepatitis C, it's about 2 to 3%. With HIV, it's only about 0.3%. So really, the risk of acquiring HIV following, an occupational exposure is actually not very high. Next. So these are the different ways in which we can get exposed. Either you get a percutaneous injury, a mucous membrane exposure, the risk is about 0.9%, and non-intact skin. Next. So why do we want to give PEP? or post-exposure prophylaxis. We know that following a percutaneous exposure or a mucous membrane exposure, there is a lot of replication of the virus in the local macrophages or in the dendritic cells. This rapidly goes on to develop to involve the local lymph nodes, and within 3 to 5 days, there's a profound viremia. So you want to break this cycle, and that is why the timing of PEP is extremely important. PEP should be given as early as possible. Even within 2 hours of the exposure, you can give PEP. Definitely within the first 24 hours. Every day that goes beyond 24 hours, the efficacy of PEP actually goes down. What is recommended is that you can give it up to 72 hours, but as early as possible is important, because this is what you're trying to block. You're trying to block viral replication in the local macrophages and dendritic cells so that you prevent the onset of HIV infection. Next. So what happens? What do you do if you get a percutaneous injury? We know very well. You wash with soap and water, mucous membranes irrigate, and non-intact skin again. You wash well with soap and water. Next. Report to whatever body is in charge of needle stick injuries in your hospital, and the specific measures actually depend on a few things. We have to assess the risk of transmission based on what event has occurred, and obviously we have to check the source for both hepatitis B, hepatitis C, and HIV. Next. So the type of injury matters. Hollow bore needles. If you have a needle placed in the artery or vein, that is also high risk. The depth of injury. If it's a deep injury, is more likely to transmit infection. The amount of blood that is important. If it's a large volume injury, it's more likely to cause infection. And also the source, the patient's source. Somebody who is HIV virally suppressed is less likely to transmit the infection than somebody who is not on therapy, low CD4 and a high viral load. Next. Yeah, so we talked about the type of injury, the severity of injury. You can just go on. Yeah. Okay, fine. Next. So test the healthcare worker at baseline, test the patient at baseline, and we need to work on all three. Hepatitis B, it depends on the vaccination status, whether you give immunoglobulins or just a booster dose. Hepatitis C, you just monitor. There's no post-exposure prophylaxis still. And for HIV, if you decide that the patient needs post-exposure prophylaxis, you will start them on therapy as soon as possible. Next. So as I told you, start within 72 hours, but as early as possible. Earlier, there used to be this confusing sort of algorithm that you would decide depending on the exposure and the type, 2 drugs versus 3 drugs. So that is all gone. Anybody who you decide needs post-exposure prophylaxis, you give them 3 drugs. You give them all the medicines right up front so that you know that they're going to complete the medicines, and you need to follow them up at 6 weeks, 3 months, and 6 months to see if they develop incident HIV infection. Next. So what are the drugs we use? So the backbone is basically we use in all adults and adolescents. What is recommended is TDF plus 3TC, and this is the preferred backbone. Now, what is recommended is that you use dolutegravir, because we know from using dolutegravir for therapy in patients, it is extremely well tolerated. So dolutegravir is what is recommended. But other agents can also be used. Boosted protease inhibitors, atazanavir, lopinavir, and raltegravir can also be used. What is recommended not to use is not to use efavirenz, because efavirenz has a high incidence of neuropsychiatric complications, and in already somebody who is very anxious and taking PEP, efavirenz should not be used. So avoid efavirenz. You can use dolutegravir or you can use a boosted PI. Next. Yeah, so the third drug actually came from this study which looked at tolerability. And if you look, boosted darunavir and dolutegravir have the best discontinuation rates, and so that's why we would choose dolutegravir as a third drug. Next. So non-occupational exposure can be IV drug use, sexual route. Again, you try and assess the same things, and if you feel that the exposure is high enough, you start them on 3 drugs for 28 days within 72 hours. Next. So this is just my final slide, looking at what is PrEP and what is PEP. PrEP is what you give to help somebody prevent infection. The exposure hasn't yet happened. Okay, but PEP is the exposure has already happened, and you still try to prevent the infection from occurring. Next. So yeah, I just talked with this, and also prevention is worth a pound of cure. And I stop with that. I don't know if you're taking questions now or later.
No.
Are there any questions from the audience? We have some questions from our virtual audience.
Do we give consideration to the viral loads in the partner, like before giving PrEP or in the PrEP? So if they are virologically undetectable, so we consider not to give PrEP or PEP, is like that?
So we know from several large studies, especially the partner study,
Yeah.
that if somebody is virally suppressed, the risk of transmission is very low. So PrEP is a situation where it is more where you don't know, that is the kind of population we're targeting. You probably not going to know your partner's viral load or whether they're virally suppressed or not. So that is what you would. That's what I think with PrEP it will be difficult to know everybody's viral load and if people who have multiple partners. Sorry? Discordant couple setting is a very different setting. Discordant couple setting is a very, very different setting. It is a monogamous relationship. You know very well the viral load. That's a different setting. So in that situation, would I give PEP or PrEP? I would not give, because we know very well, very, very large cohorts that show that. But of course, that will only take care of HIV. You're not going to prevent other STIs and all that. So those issues are there. But for HIV prevention, in somebody who is virally suppressed, discordant couple, I would not.
Any other questions?
Rajiv, it's a very nice presentation. Just quickly, can bacteriophage be used for the PEP or the PrEP?
So it has not been studied. So there are certain drugs that have been studied and they've shown that it works in that population. Whether you can just switch drugs in the same class, intuitively yes, but if you ask, do we have data on that? We don't. But intuitively, if you just switch a drug for another drug in the same class, it should work. But we don't have large data regarding those particular drugs.
Sometimes patient don't know whether he had exposure with suppose sex worker, and he cannot trace whether she is positive or negative. So in that case, they ask doctor, can we do some test, just get HIV viral load or P24, and then can decide to do with post exposure prophylaxis or not. Is that any?
No, we know that post-exposure prophylaxis, like we just said, within 72 hours latest. So the earliest your tests are going to turn positive are going to be at least a week to 10 days. So there's no point in waiting for a test and then sort of making a plan. If you think that the risk is high, commercial sex worker exposure, significant exposure, you go ahead and give post-exposure prophylaxis, because waiting for the test to turn positive or negative, you're going to lose a lot of time. And we know that PEP especially has to be given within 72 hours. And none of the tests we have can actually tell you anything in that 72 hours.
Need to add third drug or 2 drug or 3 drug.
For PEP, it's always 3 drugs. We don't have that algorithm of 2 or 3. Previously, it used to be a complicated algorithm where, depending on the patient's source, the type of injury, we would decide whether it's 2 drug or 3 drug. Now it is recommended that you give 3 drugs for everybody.
So just to answer your question, if the person is traceable, then you can ask for a test in that person and take your first dose. And then by the time your results come back, you can decide whether to continue or stop. So that can be done, but if the person is contacted.
There are some questions on the virtual platform for whether there's Indian data on PrEP.
So there is no Indian data on PrEP. There are several small studies that have been done looking at high risk groups, what is their sort of attitude and perception towards PrEP, and actually it's very, very poor. The knowledge and their understanding of PrEP and the need for PrEP is very, very poor. So only about 7 to 10% of them actually knew what is PrEP. But once they knew what is PrEP, they were, I mean, a good proportion of them were actually willing to take it. So I think we have to start right at the bottom. We have to start with creating awareness. We have to start with creating, our patient population should know about PrEP. So I think that is not there. So unless we educate them, we can't expect them to actually follow this regime.
Thank you, sir. If there are no more questions.
No, but please ask some more questions while the laptop is being set. You can ask
Great,
anything else.
Umang will always rise to the occasion.
Need not be about HIV and PrEP also.
Hi, sir. Excellent lecture. Just one question. Is there any data on PrEP or PrEP in patients with chronic kidney disease? Both of them are using the TDF backbone. Is there any data on that?
So basically, one of the prerequisites is that you have to have a creatinine clearance of more than 30 or 50 to start with. So those patients won't have even come into the equation. So I don't think we have any data on patients with either chronic liver disease or chronic kidney disease. All the patients who have been chosen into these studies are all well patients. And one of the prerequisites is to have a creatinine clearance of more than 50. So we won't have any information on CKD patients.
So any comments?
Comments are, so if someone has CKD or CLD and all that, then there is another part of the advice which we don't use, which needs to be used. So see that you never require PrEP or PrEP.
I think that's very practical advice from Dr. Soman as usual.
So there's one small comment: when patients come to us with exposure, they are quite reluctant to find the source. I mean, if they have got to somebody who's with them, they have got exposure, they are quite reluctant. Our life will become so easy if they are able to trace that person, get that test, and get out of the 28 days of treatment. No worry about creatinine, no worry about whether they will turn positive later on, 50%, 70%. They are just, so sometimes I take phone from them, call up the person and request them for the testing. Sometimes that also works.
But sometimes the source can be in the window period.
That's true.
Not sometimes, many times.
So it has to be 28 days complete.
So just one point. So today we have this regimen, tenofovir-based regimen, but PrEP and PrEP has evolved. We have even used imidavir at one point of time. So as a continuation to Dr. Umang's query, we can design the PrEP regimen if it so demands for an individual patient. I think we need not stick to what is the regimen.
Surprisingly, when I was actually looking this up, I was just wondering why dolutegravir is not at all being studied in to be used as PrEP. It's always been a tenofovir-based regimen. Dolutegravir, we use it now left and right for everything, but there have been actually no studies looking at or dolutegravir lamivudine combination or something like that for PrEP.
I think, if I'm not mistaken, the levels at the areas
the tissues are not-
is
yeah.
not good for
Yeah.
dolutegravir.
Yeah.
Especially rectal mucosa levels are very.
I have this problem that, in my clinical practice, that we do not know the source. Like, go to a commercial sex worker and come back with, say, 24 hours later. It's very easy for the HIV partner to just give, irrespective of whatever it is. I want to know what's your thoughts about if the anti-HPS antibody titers are in that, the person is less than 10. That becomes a very difficult area where you require to whether, if the titers are less, you don't know the status of the opposite person. And the only way to give is if it is the immunoglobulin, and it's quite tedious. So I don't know, how do you do that? I have this problem and I always have questions. I don't know.
So the recommendation is if your titers are low and you've had an exposure, the immunoglobulins are the way to go. I don't think there's a shortcut around that. I know it's a practical issue, but really there's no sort of shortcut around that, especially if the patient's not been vaccinated. if they've received a full 6 vaccine, I mean 3 courses of vaccine and their antibody levels are low, maybe a different thing, you can just give them a booster. But if they're not vaccinated or have no clue about their vaccination status, if their levels are low, I mean that is the only way to sort of to do it. Anybody has any other comments on that practical problem which Vasant has?
Yeah, so actually I normally just give them the vaccine, because to be giving immunoglobulin, you have to be fairly certain of the HPV status of the person to whom you're exposed.
I know, but.
Yeah, but I know it is, cost and availability and the benefit would also be an issue.
Thank you, sir. I think from prevention, we now move to protecting our most vulnerable population, that is maternal and child health. So I'd like to call up Tanu Singh, consultant pediatrics and infectious diseases at Pune, to give the next talk on ART in pregnancy and in children.
Good afternoon, everybody. And thank you, Dr. Soman, for inviting me and giving me an opportunity to meet with all my friends. So this is what the current statistics about HIV is. About 37 million people living with HIV in the year 2020, of which 1.7 million were children. Children definitely constitute a small percentage, maybe 6 to 7% of the total burden of HIV. And this is another graph from UNAIDS, which tells us about the coverage in pregnant women to prevent mother to child or parent to child transmission. And these vertical bars actually tell you that it has.
Just hold on.
Oh, sorry. It's not moving.
Display settings. Duplicate settings.
It's not moving. It's moving on my laptop. Okay, so hopefully, but it's different. Like what I'm seeing on my laptop is different from there. Okay, so I think I have to just look at those slides. यहाँ पे अलग आ रहा है. Should I just look at the screen and talk then, because what I'm seeing here are different slides. Okay. So as I said, they're just children constitute 6 to 7% of the total burden of HIV. Next. And if you look at this graph from UNAIDS, it tells you that the status between 2010 and 2020, that there is, on the right hand side, you can see that you have a rising coverage for pregnant women. 80% of the women who are pregnant are now on ART. And if you look at the number of new HIV infections in children, it is declining over time. But it is still not reached where it should, because still every year there are about 200,000 new infections in children, whereas we expect them to be about 10,000. Next. And this in a snapshot is the comparison of the adult and the pediatric HIV epidemic. So if you look at the bottom slide, that is adults, the bottom graph, and the top one is children. And so less children, 59% as compared to 82% of adults know their zero status. Less number of children, that is 54% as compared to 74% of adults are on ART. And less percentage of children, that is 40%, are virally suppressed as compared to 67% of adults. So clearly, children are not being treated as effectively as adults. Next. And this is a little bit about the status in India. And here you can see that the prevalence in adults is about 0.22%. I mean, these are all statistics. But to tell you that of the 27 million pregnancies per year, the estimated pregnancies in HIV-infected women is 21,000 per year. And the mother-to-child transmission rate is 27%. That means about 5,000 children are born every year with HIV. And if you look at this data and compare to the US data, where the transmission rate is less than 1% and only 35 children with HIV are born every year. So that is like, you know, such a marked decline in HIV in children, at least in the developed world. Next slide, please. And this is just to tell you that the mother-to-child transmission rate in India has sort of remained, you know, not very good, because it was 40% in 2010 and 27% in 2020, even though what we use in practice should be able to cut down transmission to less than 2%. Next slide, please. So with this background, I'm going to discuss the NACO and the CDC guidelines, and I will restrict the discussion to drugs that are currently available in India. And there are some other issues apart from ART which will be included in my talk. And I'm not going to discuss the individual trials because there are too many, but just the conclusion of those trials. And I'm going to focus more on pregnancy and the perinatal period as compared to pediatric ART. Next slide, please. And these are the references. One are the NACO guidelines and the CDC guidelines for perinatal transmission and pediatric ART. And of course, they're 1,500 pages and not very readable. So I have also not done a very thorough job of reading all of them, but I would request those in the audience who know to add to my presentation later on. Next slide, please. So I'm just first, in a one slide, tell you what the NACO says about prevention of mother-to-child transmission. So it talks definitely about testing for HIV in the antenatal period, also screening these women for TB as well as syphilis, and do basic labs and the CD4 count. So the viral load is not part of the regime. And the ART regime that is recommended for women is TDF with 3TC and efavirenz. The delivery method is based only on obstetric indications, and because viral loads are not tested, it is not based on the viral load. And I'll tell you what the CDC guidelines say about them. They talk about continuing oral ART during delivery, no IV ART, and then exclusive breastfeeding in the baby till 6 months, and then weaning and stopping breastfeeding at 12 months in those babies who remain uninfected, and continuing it for 2 years in the babies who are infected. And give nevirapine to the baby for 6 to 12 weeks after delivery. And TMP SMX prophylaxis in the baby starting at 6 weeks and continuing till HIV is excluded. Vaccination as per schedule, so even babies who are born to HIV infected mothers receive their birth dose of BCG, OPV and hepatitis B. And then finally, testing these babies by dried blood spot tests, first at 6 weeks, then at 6 months, and then at 12 months, which is 4 weeks after breastfeeding has stopped. So this is in a nutshell the program to prevent mother-to-child transmission in India. Next. Now, when we look at the CDC guidelines, they are more detailed, obviously, and there are a lot of components, and this is something which we would be practicing in our private practice because we want to do whatever is possible to reduce the risk of transmission. So it starts with preconceptional guidance for the HIV-infected couples that when you are choosing an ART regime for any woman in the reproductive age group, choose a regime which is safe, and we discuss what these safe regimes are. We also should keep in mind the drug interactions between ART and hormonal contraceptives. We should aim for sustained viral suppression before conception in both partners. At least for 3 months, they should have a viral load less than 1,000 copies per mil. And as was discussed earlier, in HIV serodiscordant couples, where there is full viral suppression, sex without condoms is safe. However, what is recommended is to have this unprotected intercourse at the time of ovulation to reduce exposure. But the guidelines also go on to say that PrEP is optional if the partner, even if the partner is fully suppressed, so if the other partner wants it, the uninfected partner in a serodiscordant couple, you can give it. And what is very important is to prescribe folic acid, 400 micrograms per day, to everyone, because we know that many of the drugs which we will be using have a risk of neural tube defects. So that should be on. Apart from that, the CDC guidelines also say that all women who are at high risk for infection should be tested again at 34 to 36 weeks. And also you watch them for any symptoms and signs of acute HIV infection and test them, because acute HIV infection in pregnancy is one of the biggest risk factors for transmission to the baby. And finally, apart from screening for HIV, you also screen for hepatitis B and hepatitis C, and all women who are anti-HBs negative should be given the HPV vaccine in pregnancy if they are HIV positive. Next slide, please. So moving from this, you talk about what are the general principles guiding ART in pregnancy. So the most important is to start the ART on the day of diagnosis to reduce the risk of vertical transmission. Because there are studies, observational studies, that show that if you started ART preconceptionally, the risk of transmission is 0%, and it keeps on the transmission risk keeps on rising, even if you do everything else to prevent transmission. So, because unlike what was believed earlier, a percentage of transmission does occur in the antenatal period also. Now, when we look at the choice of drug, so one is to start as soon as possible. Second is the choice of the drug is mainly determined by the virologic efficacy. Because if you look at the transmission rates, you find that people who have viral load which are below 50 copies per mil has the lowest transmission rate, whereas as the viral load goes on increasing, even if it is more than 400 copies per mil, the transmission rate goes on increasing. So that is why there is so much focus on suppressing viral loads very quickly in pregnant women. Safety and pharmacokinetics in pregnancy is also are also factors which determine the choice of ART. And as per CDC, it is recommended to do viral resistance testing in all women if they have copies more than 500,000 per mil, because you want to give the right drug quickly enough. You don't have that luxury for waiting for 4 to 8 weeks and then deciding that this drug is not working and then give it to them, because you may have caused transmission to the baby by then. And also the recommendations say that if the mother is on a regime and she is fully suppressed, then you should continue that same regime unless she is on a drug which is not recommended in pregnancy, and we'll come to that. Because this change in the ART may cause a rise in viral load and increase the risk of perinatal transmission. Next. So just to quickly talk about the drugs and how they are, what are the issues with them in pregnancy. One is the abacavir. Of course, we all know these things, that but it is well tolerated, once daily dosing. Of course, you need HLA B5701 testing, and of course, it is not for women who have HBV co-infection or who have a plasma viral load of more than 100,000 copies. So this is which is the same as non-pregnant adults. As far as TDF is concerned, we all know that there is a lot of data, a lot of experience. It is well tolerated. It has activity against Hep B. It has less toxicity than zidovudine, but there is a concern about the renal insufficiency and also on the effect on the fetus bone and cartilage. TAF has the same virologic efficacy, and studies which have compared TAF versus TDF in pregnancy have shown no no difference in adverse effects of creatinine clearance. But what was found with TAF was that you had better weight gain in the pregnant women and lower adverse pregnancy outcomes as compared to TDF. But there is the concern about long-term obesity with use of TAF. So while the pregnancy weight gain is welcome, whatever happens after pregnancy is maybe a problem. And of course, zidovudine is the standard drug which has been used for a long time, but the issue of maternal and infant anemia and side effects are the pointers against it. Next slide, please. So coming to efavirenz. Now, the efavirenz, the advantages is that it is once daily, can be administered with rifampicin, because you may have mothers who have concurrent tuberculosis. And there is no risk of neural tube defects, that has been definitely established, but there is a small increased risk of microcephaly here. Also, the virologic efficacy is less as compared to dolutegravir, though the rates of vertical transmission have not been different in the trials, and there are side effects and also the risk of postpartum depression. When you look at dolutegravir, which is the drug which we'll be mostly talking about today, I mean, there are a lot of advantages. There's good pharmacokinetic data, there is faster virologic suppression, better pregnancy weight gain than efavirenz. It's once daily dosing, well tolerated. And also trials which have looked at comparing dolutegravir with efavirenz and boosted atazanavir have shown better viral suppression at delivery. It is the drug of choice for acute HIV infection in pregnancy. But the important thing is that it should not be given with vitamins and iron and calcium, which the women are often on when they are pregnant. So you have to keep a time gap between them. And the biggest controversy about dolutegravir is the risk of neural tube defects, because there was that study in Botswana which had initially given safety signals. Now, when more data is out, it has shown that the risk of neural tube defect is about 0.16% with dolutegravir compared to 0.1% with a non-dolutegravir based regime. Whereas it is about 0.06% with efavirenz and 0.07% in women with HIV. So it is a very slight, statistically significant increase in neural tube defects with dolutegravir, but people don't know whether if folic acid supplementation was also done, whether this increase would be there or not. And raltegravir is well tolerated, and like dolutegravir, it is more efficacious even than PI-based regimes. And both dolutegravir and raltegravir are better than PI or efavirenz-based regimes, especially if the woman presents in later in pregnancy, where you want a quicker decline in the viral loads. Next slide, next please. And then finally, the main advantage of the protease inhibitors is that there is absolutely no teratogenicity. Like there is concern with efavirenz, like there is concern with dolutegravir. The boosted PIs don't have any teratogenicity, but the issues are twice daily dosing, and also with lopinavir, ritonavir, which was earlier used, there is an increased risk of preterm delivery, and therefore it is no longer recommended in pregnant women. Next slide, please. So these are the preferred regimes by the CDC, that the dual NRTI backbone should be either CDF or TAF with either FTC 3TC or abacavir with 3TC FTC. INSTI-based regimes are preferred with using either dolutegravir or raltegravir, and if you're using a PI, it should be atazanavir boosted or darunavir boosted. The alternate regimes, as per them, is the backbone is zidovudine with lamivudine, and also if you have it NRTI based regimes, they are not the preferred regime, they are the alternate regime. And the drugs which are not recommended in pregnant women is obesistat boosted PI because the levels are not enough. D40, DDI, nevirapine, lopinavir, ritonavir, and the long-acting cabotegravir and rilpivirine combination is not recommended because drug levels are not adequate. Another question is, what if a woman is on a two-drug regime before she becomes pregnant? So the guideline says that you can continue the two-drug regime in these women with monthly monitoring of viral loads and ensuring strict adherence. Next. So the practical question for us really is whether to choose efavirenz or dolutegravir, and whether to use TDF or TAF. And I think we can have some discussion at the end, and maybe other people could offer their comments on this. Next slide, please. Of course, this is the monitoring in pregnancy, and what is recommended, at least by the CDC, is that monitoring has to be much more frequent than what you do for non-pregnant people. You would have to monitor the viral load first 2 to 4 weeks after starting ART, then monthly till it becomes suppressed, and then every 3 months. And it is very important to do a viral load at 34 to 36 weeks, because that is something which will determine your other things which you will do later. And of course, drug resistance testing is important. CD4 counts are important at baseline, but then you repeat only if the people had they've been on ART for less than 2 years, or they have had low CD4 counts to begin with. If amniocentesis is to be done, viral load should be suppressed, and other labs as required. So I'm not going into details of this. So main thing is you have to do more intensive monitoring of the plasma viral load. Next slide, please. So what else can we do to further reduce the risk of transmission other than the ART? So one, of course, is you do an elective cesarean section at 38 weeks for all women who have a viral load more than 1,000 copies per mil. And the CDC also recommends intravenous Zidovudine in such women who are at high risk of transmitting the infection to their babies, of course, which we don't have here. We avoid all these invasive things like fetal scalp monitoring, use of vacuum or forceps. And we will talk about what ART has to be given in the newborn and complete avoidance of breastfeeding in the infant. And this is also what we do in our practice, especially to women who come to the private sector, that we counsel them, and most of them choose to formula feed their babies and not breastfeed, because even though she's on ART, there is a small risk of transmission via breastfeeding. And of course, the TMP SMX prophylaxis recommendation remains the same, and we have to test the infant for HIV. Next slide, please. Now, when we look at the ART choices in the newborn, you have to understand that there is limited safety data, pharmacokinetic data. You always have to do a baseline CBC in these babies. And as per the CDC guidelines, they are recommending Zidovudine in all those women who are at a lower risk of transmission for a period of 4 weeks. And in Indian guidelines, it is never been for 6 weeks. But what is different in the CDC guidelines is that if you have a mother who has a high plasma viral load, or who had acute HIV infection in pregnancy, or who had basically didn't receive any drugs in the antepartum period, or was diagnosed at the time of labor, then such a woman, the babies, after taking their sample for the HIV testing, you start them on presumptive therapy. That means you start them on 3-drug therapy with Zidovudine, Lamivudine, and either Nevirapine or Raltegravir for 2 to 6 weeks. And there's also another regime where you use Zidovudine for 6 weeks and you use 3 doses of Nevirapine associated with it. So basically, they say that because in the Indian guidelines there is no scope of giving extra therapy, but here if the risk of transmission is high, then you would want to do these other things as well. And another important thing is to watch out for mitochondrial toxicity in these babies. So if they are dull, if they're not feeding well, if they're tachyptic, you have to test them for their lactates. And if the mother has been diagnosed with an acute HIV infection during breastfeeding, it is recommended to stop breastfeeding and give presumptive therapy to the baby with 3 drugs. And of course, if the baby is confirmed to have HIV infection, then you give the baby treatment as what we discuss later. Next slide, please. And this is just to tell you that the testing of the baby is very important, and we usually use the nucleic acid test because the antibodies will be positive due to transplacental antibodies up to 18 months. So these nucleic acid tests can be HIV RNA based tests or HIV proviral DNA based tests. And the HIV proviral DNA tests were preferred before because they are less affected by the maternal ART and the infant ART. But generally speaking, their sensitivities and specificities are the same. Also, the specificity is not very good. So if you have a positive test, you would have to reconfirm by doing a repeat test. And if a baby is non-breastfed and one test at 1 month at 4 months is negative, it means that the baby has escaped infection. And the testing strategy is also different based on whether the baby is at high risk for infection or low risk. If the baby is high risk at infection, then you will test at birth, you test at 2 to 3 weeks. Because what you're wanting to do is, you're wanting to pick up infection early. Of course, because these babies are already on a 3-drug regime, it will not make too much of difference for treatment, but you would still test them quickly. And the other thing, what they do is that they test instead of, so you give this regime for 2 to 6 weeks, the 3-drug regime, and then 2 weeks after stopping the regime, you test so that you can reduce the false negativity. Whereas if the baby is at low risk for transmission, then you test at 2 to 3 weeks, 6 weeks, and 6 months. Next slide, please. Also, I just need to spend a couple of minutes here that now you have a large population of HIV exposed but uninfected babies, because most pregnant women with HIV are giving birth to children who are uninfected. Now, these babies have actually are not normal because they have increased risk of mortality and morbidity as compared to HIV unexposed babies because of the effect of the virus and because of the effect of the ART. And studies have shown that these babies have increased risk of infections, including diarrhea, pneumonia, and tuberculosis. Also, they have impaired growth, they have mitochondrial toxicity, they have impaired neurodevelopmental outcomes, and there is a higher cancer risk, And that is why all babies who are born to mothers who are infected but who escape infection themselves should also be followed up as a special population. Next. Now, very quickly moving to pediatric HIV, I think pediatric HIV is unique because of the various factors, because you basically have perinatal infection, you have higher viral loads to begin with, you have immature immune system, you have very rapidly changing pharmacokinetics, you have to use different set of tests to diagnose infection, you have different cutoffs for CD4 counts, and you have differences in the clinical manifestation. So that is why it is different. And also you have limited efficacy, safety, data and availability of the pediatric formulations. Next. So what is most important is to start treatment early, because studies which have compared early treatment with delayed treatment have shown that babies who are treated early have lower risk of infections, lower mortality, better growth, better neurodevelopment, better immune reconstitution. In fact, there are case reports of babies who were treated in the first 2 to 3 weeks of life, and then they stopped treatment at the age of 8 to 9 years, and the virus was not detected. Of course, these are handful, but long-term remission, etc., is also known. And one important thing is that babies who have been treated intensively can actually become seronegative. So if you're just relying on a HIV test to antibody test for excluding infection, it may not be correct, because they may become seronegative because you have started treatment very early and you've not given the opportunity for the baby to develop antibodies. And of course, the starting for those babies who are having infection like TB or cryptococcal meningitis, the delay is 2 to 8 weeks like it is in adults. And of course, if you're not able to start treatment, then you have to start it later. You have to keep these babies under monitoring, because one thing is very important, that you have to make sure that adherence is good before treatment is started. And there has to be strict adherence to dosing and strict attention to dosing and adherence. Next. And this is just to show you that the dosing guidelines are very extensive. Like, you for every 5 kg weight band, you have a different dose. And therefore, you have to follow up these children quickly, because as they gain weight, you might have to change the dose very frequently. So, you cannot remember these things. You have to always look at the formulary for guidance. Next. So the comparison of the NST, PI or NNRTI based regimes for children, though there is a lot of data, I'm not sharing it, but basically the PI based regimes have been compared with NNRTI based regimes. There are 3 large trials, of which one trial showed better efficacy of PI, but the other 2 showed similar virologic efficacy. And the NST based regimes have not been directly compared with PI or NNRTI based regimes in children, but it is extrapolated from the adult studies. I think these are common advantages and disadvantages of these regimes, which are same as those of adults, so I will not be discussing them. Next. So this is what the NACO guidelines are for treatment of pediatric HIV, and a lot of it is based on rifampicin use, because a lot of big children in our country are diagnosed with HIV when they have TB, and therefore many of them are on rifampicin. So therefore there is this, this prerequisite of whether or not they are on rifampicin. So in babies less than 3 years, the zidovudine, lamivudine and lopinavir ritonavir is the recommended combination. And if the baby is on rifampicin, then you super boost lopinavir by giving extra ritonavir here, or you use nevirapine. Whereas in children between the ages of 3 to 10 years, whether or not they are on rifampicin, you use zidovudine, lamivudine and efavirenz. And in all those situations where the hemoglobin is less than 9 grams per deciliter, you substitute zidovudine with abacavir. And of course, all those children who are aged more than 10 years and weigh more than 30 kg, you give a combination of tenofovir, lamivudine and efavirenz. So that is quite a simple, algorithm for children here in our country. And next slide, please. And if you look at what the recommendation is, next slide. If you look at the CDC guidelines for pediatric ART, they are actually quite complex, and they are like, for example, in the first month, you give 2 NRTIs with raltegravir, and here you would use zidovudine with either 3TC or FTC. Between 4 weeks to 3 years, you can basically you move towards a dolutegravir based regime, and after 6 years, you again, what is recommended is also either dolutegravir based or bictegravir based regime. If you look at the nevirapine based, it is only recommended in the first 2 weeks, where you have for preterms, because you don't have dosing guidelines for raltegravir for preterms, and even lopinavir, ritonavir, there's a very small window between 2 to 4 weeks you can use that. So this is a little complicated here, and it is quite different from what we use in what is recommended by NACO. And all the other regimes like efavirenz based regimes, nevirapine based regimes, lopinavir, ritonavir based regimes beyond 4 weeks, etc., raltegravir based regimes beyond 4 weeks are all in the alternate regimes. I think you can't see them, but they are down in that slide. Next slide, please. And some of the drugs which should never be given in children are basically triple NRTI regimes, or once daily dosing of lopinavir, ritonavir, darunavir boosted regimes, efavirenz based regimes for children less than 3 years, because you need a lot of pharmacokinetic data, and otherwise your drug levels may be less, and so on and so forth. So there are some drugs which should not be given in children. Next slide, please. And this is how you would monitor the children, and I won't go into details, but just want to tell you that the cutoffs for CD4 count are different in children, where you would call anything more less than 750 age below 1 year as normal, and less than 500 between the ages of 1 to 6 years, and less than 200 above the age of 6 years as severe immunocompromise. Next slide, please. And when we talk about adolescence, there's other issues which come here, like adherence issues, and you need to modify the dose quickly, because as they mature in their Tanner staging, you have to use the adult data, adult dosing. Otherwise, what will happen is that you will give them a higher dose and you will have more toxicity. Also, substance abuse, pregnancy, not so much of a problem in our country, but in other countries is there, and you have to transition them to adult care. Next slide, please. So I think with that, I would like to end my presentation saying that now pregnancy is now possible in serodiscordant couples where the infected partner is fully suppressed without an increased risk of transmission, because earlier there was sperm washing and all, and now you don't even need PrEP here, because the partner study showed that the risk of transmission is negligible. So that is not an issue, but you have to, but it is very important for preconceptional counseling with choice of the correct regime and folate supplementation, as well as making sure that both partners are suppressed for at least 3 months before they conceive. We should start ART on the day of diagnosis if we come to know if a woman who is pregnant is detected with HIV infection, and dolutegravir is now considered as safe. There should be regular monitoring of adherence and viral loads in pregnant women, more than what we do in non-pregnant adults. And in non-government practice, you can use other interventions to reduce the risk of transmission, like elective cesarean section, etc. And again, you have to pay full attention to the testing in the newborns, as well as the choice of regime, and you can offer presumptive therapy to those newborns whose mothers did not receive adequate ART. And as what you can see from my presentation, that INSTI-based regimes have now become the standard of care beyond the first 4 weeks of life. So whether it is a young child, whether it is a child, adolescent, pregnant woman, adult, I think it's all INSTI-based regimes. Thank you so much.
It's an excellent lecture. I don't know how you managed to concise pregnancy and childhood ART in one short span of time. Are there any questions? Although it was an excellent, completely comprehensive lecture.
Would you suggest abortion in a newly detected pregnant woman who has low platelet count and other HIV related complications? Because I had one patient who had 10,000 platelet count and subsequently she was found HIV positive.
No, I mean, when she does, it tells her that she has very advanced HIV disease. But it also depends on if she's come within, I mean, you were considering abortion only if she's come within the first 12 or 20 weeks. So I think you have sufficient time to start antiretroviral therapy, make sure she gets suppressed viral loads, and carry on with the pregnancy. Because as you know, the risk of transmission, even in a situation like this, if you give a regime and do other things, is going to be less than 3 or 4%. So it is not an indication for abortion, at least a medical indication for abortion. Yeah. And that is also what is recommended is that if you are having a woman who comes late, who comes with advanced disease, then INSTI-based regime is what is preferred.
Yes. I have started on INSTI-based and conservative management with regular USG follow.
Yes.
You said so much about the weight band and adjusting those and so on. I find it very intriguing that in adults, letting be 45 kilos or 120 kilos, we don't go by weight band at all. I mean, I don't know this question. Can Sanjay or Dr. Ganga, anyone, what is that about?
Metabolism.
Yeah.
Cytochrome enzyme maturation, which happens in kids as age advances. And I think for weight, I'm not really sure why you should be looking at it. But in adults, even if it is obesity, it doesn't really make a difference. The plasma level is drugs are slightly possible. So, and particularly NRTIs, PI. So you need to screen blood. So Robert Gallo and his colleagues actually detected antibodies, and then subsequently serological tests were developed from these studies. Got started about. Okay. So initially it was all, as we know, a lot of opportunistic infections, PCP, CMV, etc. So the first antiretroviral drug was actually tested, and it was AZT, which was developed by a guy called Jerome Horwitz for cancer treatment in 1960s. And it was a drug which was in the lab along with various other drugs being screened for activity against HIV and was found to have activity. So it was an incidentally discovered that AZT worked for HIV. And soon the first trials in advanced AIDS patients showed that at least in the short term, its prevention of progression was achieved by using AZT as compared to placebo. But soon enough, this was very short-term effect. And that is one of the reasons for that was obviously development of resistance. And in the first decade itself, we knew that this was mediated by mutations in the reverse transcriptase enzyme, and this was 67, 70 to 15 to 19, which later on came to be known as TAPS, as we know with AZT. Mark Weinberg and colleagues actually demonstrated that it's not only if you develop these mutations against AZT, but against a variety of other drugs in the same class like DDC, DDI, D40, etc., which the same mutations leads to cross resistance. That means even if you had drugs available from the same class, you can't use it because if you have developed resistant mutation to one drug, you'll have cross resistance. So that was a very struggling kind of era. Where is he? So now let us go into the second decade where there was a era of hope. The first thing which came in the second decade was quantification and realization that we can measure molecularly HIV in the plasma. And now we know this as plasma viral load. It was very interesting in this study that they showed that while the CD4 count is stable, there is high levels of viral replication happening. That means right from acute seroconversion throughout the natural history of HIV. So this important discovery suggested that HIV is continuously replicating and high levels of virions are being produced. And that is essentially which triggered the mantra of hit hard, hit early. David Ho and his colleagues demonstrated that not only is there a rapid turnover of plasma virions, but also there is a turnover of CD4 lymphocytes simultaneously happening. So there is a constant tug of war going on between these two, leading to regeneration of CD4 count, maintaining CD4 count levels till certain point of time. And this essentially translated into that you can't leave HIV like that in the plasma, replicating at high levels. So you need to treat it. And if you want to treat it, you need to treat it early, in early stages because viral replication is high, and you need to treat it hard because we already know that just an AZT is not going to work at such high levels. David Ho, as we all know, in 1995 was named Time Man of the Year. So that is something which is quite important to acknowledge. John Mellors and colleagues, they had a very long cohort called MACS cohort. This was a cohort of homosexual men. They've been following up for a long period of time with stored plasma. What they demonstrated that if you have value of viral load available, you can actually use it for prognostication. So we now know the concept that we used to talk about, both viral load and CD4 are important in prognostications. While viral load is speed of the train going towards a broken bridge, CD4 is where the train is now. So that came from John Mellors' study, and this diagram show you the various Kaplan-Meier curves showing the proportion of surviving stratified according to CD4 count and viral load. So very importantly, that gave us an idea that we need to reduce the viral load so that we can give good prognosis to our patients with antiretroviral treatment. The issue came up then that you need to use two drugs. Why not use two nucleoside analogs? And Scott Hammer and David Katzen's time. Many of us may have seen in meetings in India. Both are unfortunately not. They died last year. David actually died of COVID-19 in Zimbabwe in Jan 2021. So these ACTG 157 and another study called Delta looked at the combination of AZT-TDI, AZT-Salzitavir, and they found out that it was more effective than AZT versus TDI monotherapy. But remember, the primary endpoint here was still clinical. They were not using viral loads as surrogate endpoint to assess treatment response. Trip Gulick and colleagues for the first time published data on 3-drug antiretroviral treatment, which we now call as highly active antiretroviral treatment. They looked at using zidovudin, lamivudin, entecavir and compared it with 2 drugs and entecavir monotherapy. They used HIV RNA less than 50 copies as a surrogate marker rather than waiting for clinical progression, and demonstrated superiority of 3 drugs as compared to 2 drugs. Soon enough, people realized that as we are using PI-based antiretroviral therapy, Frank Palella Jr. Demonstrated in his study a dramatic decline in AIDS-related deaths happening with the use of protease inhibitor-based highly active antiretroviral treatments, one of the most cited studies in the AIDS pandemic. The success was so mind-blowing that people started looking at, when you reconstitute CD4 count, can you discontinue prophylaxis? So the earliest data for discontinuation is in the second decade, where it was supposed to be safe to discontinue PCV prophylaxis with TMPSMX if your CD4 has reconstituted to move into 100. Planck, Netherlands guy, along with colleagues, was the first to describe the concept of low-dose ritonavir boosting. We actually saw that you need to use high pill burden, thrice daily regimen. So why not use a low-dose ritonavir to boost? And this PK study shows increased exposure with a concomitant PI with the low-dose ritonavir. Planck was president of IS, unfortunately died in a plane crash, Malaysia, which was shot over Ukraine. During that time when he was traveling to the International AIDS Conference in Malaysia. Soon there was also realization that not all is very good, and Andrew Carr and David Cooper from Australia demonstrated a peripheral lipodystrophy syndrome. And this was lipoatrophy, lipohypertrophy, and this was the first few cases that was flagged by this group of researchers. Martin French from Perth demonstrated that iris is also a problem in advanced HIV infected individuals, particularly when the CD4 is less than 50. And the first few immune restoration diseases were for MAC infections and the Mycobacterium tuberculosis. So we already knew there were problems with the antiretroviral treatment. There was an idea that if you are able to reduce viral load to less than 50 copies per ml, you may be able to eradicate HIV. Because by taking it for maybe 5 or 10 years. This idea was really destroyed by a guy called Bob Silicon, who demonstrated that latently infected CD4 cells are there. And this basically are latent, but they are infected. As soon as you remove ARB drug pressures, they will rekindle the plasma back. And he calculated the half-life of this long-lived latent CD4 cells, which was around 50 months. And showed that it would take around 70 years of continuous antiretroviral therapy to eradicate HIV theoretically. So this essentially translated into a concept that heart will be lifelong. So that's an important advance to realize that heart is going to be lifelong. Then people started realizing that it's because of the toxicity of the drugs. Why not start with 3 drugs and get it down to 2 drugs? This is the induction maintenance strategy by Dan Havlier in the ACTG 343 study, showing that induction maintenance does not work. So if you start with 3 drugs, you can't come down to 2 drugs, either entecavir monotherapy or the double lamivudin. Simultaneously, because of the problems with protease inhibitors, people started looking at other core drugs, and this is NNRTF. In the first INCAS trial by Julio Montana in Vancouver, Canada, demonstrated that the combination of zidovudin, and nevirapine was superior to 2-drug combination, heralding the onset of NNRTS as an alternative to boosted protease inhibitors. Stefano Vella from Italy and colleagues demonstrated also that the goal of antiretroviral therapy should be a viral load less than 50 copies. Remember, previous studies demonstrated we're looking at around less than 400 copies, but less than 50 copies in this elegant study showed is able to maintain durability of virological response. So this is a concept which came from one of these important studies. At that time, in the second decade, genotypic resistance testing was available in research settings. So it is in this study, a randomized trial called the Virat study. They demonstrated that if you choose antiretroviral drug based on genotypic resistance testing when you sequence with failure, you do better for your patients as compared to now. So the birth of genotypic resistance testing as a utility in sequencing, one of the first papers was actually in the second decade. In terms of prevention, one of the most important advances happened in the second decade. A new door was opened when a three-phase AZT single dose regimen in the PACT 076 trial demonstrated reduction in risk of mother-to-child transmission from 25% to 8%. So that is something which is heralding concept that it can use ART for prevention. And this is the first group which was basically targeted for prevention with ART. Around same time in the archive, Thomas Quinn from Johns Hopkins showed that heterosexual transmission of HIV is tied with plasma viral load. So if your plasma viral load is less than 400 copies, in some settings less than 1000 copies, the risk of transmission is negligible. So the idea that viral load correlates with sexual transmission was available in 2000. So that idea, fructifying into treatment as prevention, took another decade. So we go to the third decade with this an era of consolidation of whatever has been achieved in the second decade. And it was soon realized that not all nucleoside analogs are safe. So in this study, for example, it demonstrated AZP3TC paired with efavirenz is better than T40DDI paired with efavirenz. Or it was also demonstrated that just using not all three drugs are same. You can't combine three NRTIs like AZP3TC abacavir in this trial versus combined versus efavirenz with two NRTIs and showed that the triple nucleoside group is inferior, so you can't use it. People also were ambitious to look at whether you can use 4 drugs. So you use 3 NRTIs with efavirenz and compare it with 2 NRTIs with efavirenz. We did not find a significant difference in these populations. So all of these things were eliminated as we were progressing to understand the treatment. Patrick Kenny from France at that time published in AIDS important previous side effects were believed to be PI related, but he published that T40 was significantly associated with lipoatrophy, and this is a study in a sub-study from a comparative clinical trial. So that was a signal that T40 is causing problems. That invented look for new drugs, and this is the birth of TDF, Joel Gallant. Actually, in the 903 study, compared TDF with Stavudine and demonstrated initially non-inferiority and subsequently superiority when combined with efavirenz. So TDF became an interesting drug that should be used, and the D4D and AZT were going on during this time. Simultaneously, in the later part of the decade, you had new third core drug, that is integrase inhibitors, Jürgen Rockstock from Germany. He worked on raltegravir for quite a long period of time, and this is the STARTMOD trial which demonstrated non-inferiority of raltegravir with 2 nucleosides versus efavirenz, which was the standard of care at that time. Very early in the decade, Steve Dix and colleagues demonstrated the concept of fitness, and this was basically drug mutation associated fitness. We all know about the 184V mutation. The idea of continuing a 184V 3TC came with the Steve Dix study, where he demonstrated that if you continue the same regimen, your viral load going up, the slope is lesser than discontinuing treatment, where there is a rapid increase in the viral load. The other issue was adherence, and David Bansberg actually demonstrated that adherence levels to achieve virologic suppression is not on function only of how much you take the drugs, but also what drugs you are using. So that brought in the concept of genetic barrier to resistance. So essentially, if you have lower adherence to a high genetic barrier to resistance, then you would perhaps get away with it as compared to say an NRTI, which has a lower genetic barrier, where high levels of adherence are needed to achieve virologic suppression. People also had problems in terms of toxicity, so they tried many things. So one of these was intermittent ART. It was not a smart idea. This is a smart study which demonstrated that CD4 guided treatment interruption was not effective. On the contrary, it was actually causing increase in not only AIDS-related illness, but also non-AIDS related illness. This is one of the first trials which demonstrated non-AIDS illnesses as an important component of HIV clinical presentation. People also wondered whether you can improve CD4 counts by giving immunostimulants. This is the Spirit Silicate trial, which demonstrated that IL-2 when added to antiretroviral therapy improves the CD4 count, but doesn't provide clinical benefit. So essentially, just improving CD4 counts is not sufficient to provide a clinical benefit. And finally, Andrew Zolopa demonstrated in a randomized controlled trial for most opportunistic infections except tuberculosis and cryptococcal meningitis, which were excluded from this trial, that should start antiretroviral therapy within 14 days of stabilization of an opportunistic infection. So this is where the data comes from of when to start ART inactive. In the last part of that decade, you had the first data coming from the IPEX trial from Robert Grant, who demonstrated that a pre-exposure prophylaxis amongst men who have sex with men with TDF-FTC was associated with reduction in incident HIV infection as compared to placebo. So the benefit of ART in another indication was first demonstrated in this trial. Finally, let us end with the fourth decade. And this is where we are trying to attain perfection in antiretroviral therapy across all indications. The first is we had an answer to when to start ART in active tuberculosis. There were 3 trials, and this is Salim Abdul Karim from South Africa, who was a PI for the SAPIT trial, and then we had the Camellia trial and the CIDS study. All these 3 trials showed that if your CD4 is less than 50, you need to initiate ART within 2 weeks, preferably within 2 weeks, and if you can, we wait for 4 to 8 weeks if your CD4 is above 50. So the risk of progression versus weighing the risk of iris was something which was demonstrated in these 3 studies. These are practice-changing studies published during the 4th decade. David Bolwer again demonstrated that in the COAT trial, in cryptococcal meningitis, patience is virtue. You need to wait for 4 to 5 weeks and then initiate antiretroviral treatment. And in this COAT trial, deferred ART was associated with higher cumulative probability of survival as compared to early ART. Till that point of time, INH for IPT or treatment of latent tuberculosis was popular for 6 to 9 months. But then this was associated with problems of adherence, etc. And this was Richard Chassin who demonstrated that you can use short course regimens in HIV infected individuals for preventing tuberculosis, including weekly rifampicin isoniazid, rifampicin isoniazid, etc. So the efficacy of these short course regimens for prevention of TB was demonstrated earlier on in this decade. Perhaps one of the most important studies is also the START study. This is Jens Lundgren and Sean Enright from Australia, where they demonstrated that immediate initiation of antiretroviral therapy when the CD4 is more than 500 versus waiting for starting antiretroviral therapy when the CD4 was to initially less than 350, but later on moved on to CD4 less than 500. They had a problem in terms of increasing risk of progression, both for AIDS as well as non-AIDS illness. So this study is where we get this guideline that you need to start antiretroviral therapy ASAP for everybody. The problem with TDF was also being realized. It had some bone and renal toxicity, particularly when it is paired with a boosted protease inhibitor, but not essentially with a non-boosted core drug. And it showed that maybe you can use another prodrug of tenofovir, TAF, and Paul Sachs demonstrated non-inferiority when you combine it with dolutegravir with popecistat in this trial. And this was where the birth of TAF happened. Why less is more? Because the dose of TAF that we are using is 25 milligram or 10 milligram of the boosted protease inhibitor. It's way lower than 300 milligram of TDF. Then another integrase inhibitor came in from, this is Sharon Walensky, who was a PI for the SPRING trial, which demonstrated that at that time when you have efavirenz as a standard of care, it was non-inferior. So again, this is an important new drug which can be used in naive patients. And DTG then came into being. We had data on that from 2030. But DTG was seen as a wonderful drug, and it was seen as a wonderful drug across the treatment spectrum. So this is a Downing study which demonstrated that in the second line, when you fail with an NNRTI-based regimen, dolutegravir was superior to lopinavir when you change the backbone nucleosides. So the Downing study essentially was stopped because it was the DSMB stopped it. So that means that you can use DTG in second line if you fail an NNRTI-based regimen, but then you need to perhaps modify the nucleosides. But even that is not needed. In the Nadia trial by Nicholas Patel, he demonstrated that if you recycle tenofovir from your first line, when you're failing an NNRTI-based regimen, you can still have excellent activity. And there's 96 weeks data from PRI 2022, just 2 weeks ago, from the same trial, which demonstrated superiority of TDF, even when recycled, over zidovudine in second line, when it is paired with either DTG or darunavir. So this is something which is path-breaking, and so perhaps you would really see this guidelines change over the next few years. DTG is such a wonderful drug that people started looking at why not use it 2-drug regimen. So this is Gemini 1 and 2 trial combined analysis from Pedro Khan and colleagues, which demonstrated non-inferiority of a 2-drug regimen in antiretroviral naive patients with as compared to 3-drug regimen. So DTG 3TC is surely less is more, except few small caveats. Maybe we can discuss it later. Why not use DTG 3TC in patients who never had resistance to both these drugs? In simplification, and these are now 2 studies are available. SALSA, I'm showing the data from the TANGO study, where TAF-based regimen was randomized to change to DTG 3TC or continuing TAF and demonstrated non-inferiority. So essentially, so you can see here the range of clinical indications where DTG can be used. Till that time, you had another ARV coming in. This was another triumph, another integrase inhibitor, bictegravir, and it demonstrated non-inferiority in this study. So we have another option of bictegravir combined with TAF-FTC. Unfortunately, only that combination is available. In terms of prevention, this is at that time in the year described as the science paper of the year for the Science Journal. And this is the HPTN-052 study. Myron Cohen and colleagues demonstrated that in serodiscordant couples, if you randomize to early antiretroviral treatment versus delay, the risk of sexual transmission, linked sexual transmission, not unlinked, is associated with reduction in treatment in the group with the early antiretroviral. So this is the first study showing you that treatment is prevention. And if you achieve undetectable viral load, the risk of transmission. But in this trial, the problem was they were also advised to use condoms. They are also advised to use other modes of prevention. So essentially, this meant that you really don't know if condomless sex and having a viral load undetectable is able to prevent HIV. This was answered by Alison Rogers, where she demonstrated in MSM population in the partner study that the risk of transmission, and see those point estimates are all 0, and the 95% confidence interval is unsure because the sample size across various sexual activities is small. So they demonstrated very clearly that if you're undetectable with condomless sex, you're untransmissible. So this is where you get this idea of U is equal to U. And then of course, this is what we discussed, the impact 2010 study, which demonstrated that TAF-FTC DTG was, of course, virologically superior to efavirenz, but was also associated with lower probability of maternal and neonatal outcomes. But then there is a problem also in this era. We also could see weight gain happening, particularly in Black African women. And this is quite significant. This is from Paul Sachs meta-analysis showing instills associated with higher weight gain as compared to PI and NRTI, as well as TAF, which is associated with higher weight gain as compared to other nucleosides. Finally, there was this interest in injectable ARVs. This is version 1.0 because it's going to evolve very rapidly in the next decade of a new treatment approach, with injectable cabotegravir and rilpivirine was associated with non-inferiority with continuing antiretroviral treatment. This was the Atlas study, I think, which was giving these drugs at 4 weeks interval. Now we have the Atlas 2M study, which gives it at 8 weeks interval. So we are looking at something which is quite exciting. Why not use injectables for PrEP? And this is cabotegravir in cisgender men and transgender women. Now, up till now, the standard was TDF-50C for PrEP, and here it is shown that cabotegravir was actually superior to TDF-50C in terms of enhancing HIV prevention. So that benchmark is also going to change perhaps in the next decade. So in summary, I think this has been a spectacular journey. I've been part of this for quite long now. It has been, very tricky. Sometimes you are on the wrong way. Sometimes you have your own way of treating patients. Sometimes it's the right way, but you need to follow evidences. And most of the times it can be a complete U-turn. We know this is a classic example of when to initiate ARV. It started with hit early, hit hard. Then it changed to hit whenever needed, but hit hard and wisely. And then now it has come back to hit hard, hit hard. So essentially you do a complete U-turn. In this, we have this BTG neural defects. Initially it's problematic, don't use it, now use it. So there may be lots of examples of U-turns which may happen in this journey. But let me end by giving you a quote from Jonathan Mann, who was the GPA, Global Program Leads, WHO, who also died in suicide flight in an accident. And why I'm showing you this quote is HIV is not just ART or medicine. HIV has a bigger aspect to it. There are social, psychological aspects to it. And as a clinician, you should be also willing to take care of those aspects. So he says that when the history of AIDS and the global response is written, our most precious contribution may well be that at this time, we did not flee, we did not hide, and we did not separate ourselves. We basically went ahead, we treated these patients, and in the whole world actually, and we basically had the courage to work with these patients. So I think that's all. That's my alarm. Thank you.
Everyone is speechless.
Everyone is speechless except the chairperson. So the chairperson will have to get some.
I saw some of them writing. So, I can. It's a nice exposition of how things happen. One of the things which is more unforgettable for me was Concord trial. Concord changed the way we were thinking at that time, and it actually in Concord they compared the early initiation with AZT versus late initiation, and they found no difference. And that led to thinking that there would be emergence of drug resistance, which would be an important issue. Subsequently, many of us may remember that actually it led to development of sequential regimen at that juncture. And what was worse was there were accusations that the pharma companies knew stavudine and zidovudine actually have the same profile. But at that time, the drug resistance was not available outside the pharma sector. The second, perhaps, thing which I would think which made a major difference was that use of single dose nevirapine for MTCT. leads to emergence of drug resistance. Because with that, we also understood that NNRTI resistance can be very difficult to handle. You need to, and then the 3 drug regimens that followed at that time, that was something which I feel is one of the issues. Then, now with the COVID background, I forgot, I didn't write down because when you were going through, there were thoughts that came in. Now I'm old enough now to forget the whole thing. Now, one thing which I realized at the backdrop of COVID, though this is an acute infection, we still call it as an acute infection. People could still debate post-COVID could be part of the COVID infection in itself. But if we compare that, though this will be oranges and apple, there is one thing which emerges very strongly. And that is, even if we reflect, we took 40 years to come to this particular place now. But if you actually look at COVID, we moved very rapidly. Each one of them have risks and benefits. But now when you look back to what was happening, in HIV medicine, we refined the ways clinical trials could be designed really well and done rigorously. Whereas the adaptive trial pattern, which was actually emerging for all other studies, if you look at behavioral studies that were done in those early days, they were using adaptive trial, but we did not adopt adaptive trial. And the result is each trial took a long time for action per se. Now, if I reflect on the other issue, what was interesting when I was seeing all this, one thought came to my mind. That public health policies, when you look at NACP, and look at the delays, once the evidence is generated, how much of time did you take to convert it into a guideline or policy? If you actually look at PCP related PCP prophylaxis or OI prophylaxis, it came up within a period of 3 years. I recall it was Dr. Sengupta used to be leading the show at that time. I think it was 1991, 92. It was the first effort done by NACO that they started with OI prophylaxis. But look at AZT as the first drug. Now, one of the things which I felt you should have given credit to Cipla.
Yeah, I was going to say it was not part of.
No, but actually,
I mean, it's the first FTC.
Yeah.
Yes.
Yeah, not only first FTC, the cost was a huge issue, which they broke the barrier, and that's why wherever we are, perhaps newer drugs kept on coming because there was always a hope and nobody struggled. Earlier days, if I recall, in the AIDS conferences, the PLHA groups used to destroy the manufacturers' stalls, actor. But that went off because that hope started because of Cipla. That's what. Now, you look at how much of delay, and I think cost is the main issue. Now, we took PCP prophylaxis quickly. For AZT, it took 1997 for Cipla to produce AZT, and then the cost was still pretty high. People started using somewhere. But you look at nevirapine as a single dose or AZT as Bangkok region. No, I think it came around 1998. Within 1 year's time, since this was a single pill and the pill was being produced, first it was Zero-Day. Pill was produced by an Indian generic manufacturer. So essentially we went off rapidly, and within 4 years' time, PMTCT as a within 4 years, 1998 to 2001, early 2001. I think it was March or something. We started off first with AZT and then we moved to nevirapine very easily. You look at ART, 3 drug regimen. It started sometime in 1996. 3 drug regimens are good, and the definitive evidence came in 1997. we took almost 2004 to say yes to use of ART, but I think that's a very bold step because lifelong treatment was never given in any Indian program so far. Then you think in terms of adoption of PrEP, we took huge amount of time. Even today, there is a lot of resistance for PrEP because one, it may be unmanageable, the cost could be prohibitively high. The pill may be very cheap, but the kind of diagnostic test that you have to do to administer for a program, it's something which is very difficult. You look at HPTN 052. In HPTN 052, though the trial results were in 2011, if I'm not wrong, and we took almost 5 years time to actually adopt treat or what we say,
Treatment as prevention.
Treatment as prevention, or all those who are diagnosed, we
Test
have
and
test and treat policy. That took more than 5 years. Why am I mentioning this? I think everything was guided by cost considerations rather than the discovery mode that we had. And even now, when you look at COVID, one wonders, could we not have had shortened the durations of study using different approaches? Though I must admit, clinical trials actually developed with HIV. That is a massive change with respect to different study designs. But it happens. I would, if I'm going to stop, if there are no questions, any questions people have? Yeah, please go ahead.
Sir, is that injectable pyrotography is available? Yeah.
Not in India.
Right. And which OIs you told that we treat OI first before starting the ART? Are there any OIs that we need not to wait to start the ART?
For the OIs which don't have specific treatment, you essentially start ART. So that is let's say PML equal to score uses. These are the OIs where you don't have specific treatment. You start ART. Other all OIs for which specific treatment is available, you treat it, and then within 2 weeks, except for TB and cryptomeningitis, you would initiate.
Just two things, because people may think that. Two things which were also important as landmarks. Therapeutic vaccines failed, and therefore the entire area of scientific development was stopped altogether towards therapeutic vaccine. But now you have PNAPs. PNAPs are showing very encouraging results and may soon find their place in guidelines.
If they are sensitive, that is declare trial, which
appears as if.
But not alone, sir. It is with Romidepsin.
I know.
For many decades, I was just, for many decades, when we practiced in India, we always felt we were a decade late in adopting things which narrowed with the last decade. So, in the last decade, we immediately got, not in public policy, but
even in private practice.
So, technology was available right now. I mean, in the fourth decade, it was single trial.
DTG was part of national guidelines. It is not that it was treated as an alternate regime, not the first regime. No, because they take almost 1 year to procure a drug. So that was the issue. Alternate drug, it was there right away. I think I wouldn't say. I think the course has been rapid as well as slow, and that's why I said perhaps cost considerations made a lot of difference. Sir, Ola.
Well, I don't have words to how should I start? Because yes, sir, 2002, exactly 20 years back, both the stalwarts who started the courses for all other institutions like us. And I'm very thankful that not only me, but a lot of people across India have been benefited by efforts of both of you. I think everybody who is sitting here should give a great round of applause for this student. Coming to that, he is asking a null set of No, now I am going to ask the question. You are told all about the 40 years, 4 decades. What expect you now? Because we all know that HIV treatment is not treatment of increasing the CD4 and decreasing the viral load. We do have a lot of challenges to come with knowledge, signets, low level malaria. So what you see in future, is it the same ARV which is going to, or there are any additional things which you will have to?
So if you look at clean patient, naive with some treatment, you initiate an integrase inhibitor in proper resistance doesn't develop. There's no known resistance developing in clinical trials on a DTG-based regimen to either the backbone or DTG, unless it's functional monotherapy or very partial activity. So I think improving on this is very, very difficult. So you would essentially look at trying to improve adherence because this is lifelong. So the already injectables are there. We need to look at the feasibility of implementing that and the acceptability of our patients for an injectable treatment. So those would be as far as ART is concerned. In terms of NCDs, I mean, there is data to suggest that NCDs occur at higher frequency in HIV infected individuals and residual inflammation may be driving it. So the whole focus now is to look at whether you can reduce residual inflammation in addition to ART. And this is REPRIVE trial, which is actually ongoing, which is looking at pitavastatin plus ART versus ART to reduce some of this, prevent some of these non-AIDS comorbidities in naive patients. There are other studies with methotrexate and ACE inhibitors, ARBs, which have not been found to be having good anti-inflammatory, and aspirin also in HIV been found. So I think that focus will be there. But increasingly resistance seen an MDR patient is not going to be very, very common. We have also stopped doing resistance testing now for our patients. Doesn't really make sense. Very rarely you may get a patient who has been exposed to sequential drugs. So that is where you really have your little. Otherwise, it's actually a no-brainer.
Sanjay, thanks for that excellent lecture, and thanks also for mentioning Jonathan Mann at the end. But I think one of the things which doesn't come into all these data and clinical trials is an important lesson from last 40 years is unless the communities were involved in this, community empowerment, community involvement, because unless there were groups who were bashing those stalls, the cost may not have come down. So it is taking your own lives in your hands by the people, and I think before the ART came and viral loads were suppressed in sex workers, it was the unionization, empowerment of the sex workers that contributed actually to a lot of prevention in our country. And I think that never gets mentioned in those histories of 40 years. And I think it's an important aspect which should be there.
No, I actually was thinking about all this. I had included a slide with Rock Hudson, Freddie Mercury, and Magic Johnson as celebrities who came out that they said they had AIDS, and that brought the focus of the policymakers to it. But I removed it because Rajiv wanted me to talk on only HIV medicine and ART. So that's why I focused.
So the blame is at my doorstep.
At the same time, when he is mentioning that patent pooling as a mechanism came up because of HIV. Earlier there was no patent pooling, no voluntary licensing, but it was the efforts of the active group that actually pushed them so much that patent pooling came up. And then our people started challenging the patents right and left. I I think some of the people must actually be mentioned. No? The kind of work that Anand Grover's group did to fight against patents. I'm not talking of other basic human rights. But I think, in a way, one way to summarize is perhaps this is going to be the first viral disease, which is chronic infection per se, which may be potentially eradicated by 2030 for sure. No, and that's the reason why you are adding all to the whole campaign. Like you have now elimination of congenital syphilis as a part of it. You look at hepatitis B, they are also hepatitis B or C. Both are riding heavily on national AIDS control programs. And if you look at their strategy, the strategies are good. Now the question is whether you will be able to implement them, given the fact that COVID has disrupted network as well as access to a larger extent among them. Thank you, sir. Thank you.
Thanks, Raju. It was very nostalgic.
No,
It was very
it's like listening to Bhimsa and all.
Thank you, sir. A spectacular talk on a spectacular journey. And from here, we go to challenging cases in ART, which hopefully will take us through a lot of twists and turns and the roller coaster ride by itself. I'd like to call the presenter, Dr. Vasan Nagvekar, sir, consultant infectious diseases at Leeravati Hospital, and the panelists, Dr. Piyush Chaudhary, consultant infectious disease at Jahangir Hospital, Dr. Mahesh Lakhe, consultant ID at Columbia Asia Hospital, Dr. Sanjay Pujari, sir, and Dr. Rajiv Kartik. So in the panel discussion, what the aim is first that the questions would be first aimed at the audience for participation and then given to the expert panel for discussion.
So good evening, everybody. At the outset, thanks to CIDS and Soman sir for giving me this opportunity. And after three things, one is going through 40 years of exposure. Dr. Sanjay Pujari took us through a museum of history to walk through. Then Dr. Sir Ganga Khedkar's his comments. And the third thing is the last part what Dr. Pujari said, that we are hardly doing any resistance testing after the integrase inhibitors. So hardly any interest has been left really in the practice, because you just switch over to an integrase inhibitor and you're sure that it will work. And my exposure to genetic resistance testing has not been very great, because I did my ID in 2010-11. I started my ID practice in 2012, and by then the integrase inhibitors were already into the market. And I still remember in the initial part, 3-4 years, where I used to do genetic testing, but of late, I hardly remember once in a while, because we straight away switch over to integrase inhibitor and see whether patient inhibitors. I'll take you to 3-4 cases and see whether it brings interest, because Dr. Sanjay Pujari extensively, I think, covered majority of the part. So first case is a 51-year-old man who was diagnosed with advanced HIV infection complicated by cryptococcal meningitis. Baseline laboratory tests for absolute CD4 count was 16 with a viral load of 37 lakhs. A pre-treatment genotype, which this is from again I'm telling this is not my own case. Genotype which had a testing revealed a H1 HIV1 subtype B with L74 mutation. So, what is the significance of this mutation? Because the case goes on. Does it have any significance of this L74 mutation?
So I remember L74V mutation that was associated with Abacavir PDR.
So this is just taking to the theoretical part. I mean, practically we are not going to be just going to this. So the L74I mutation conferring high level resistance to diadenosine and intermediate level resistance to abacavir, and possibly L74V would be through abacavir. The person was started with bictegravir 50 tab around 42 days after the HIV diagnosis. Completed 2 weeks of induction therapy with intravenous LAM and oral 5-flucytosine, followed by 4 weeks of consolidation therapy with oral fluconazole for his cryptococcal infection. After 4 weeks of therapy, viral load was 30,000 copies, significantly low because it was 37 lakhs. After 11 weeks, his viral load was 319. The absolute CD4 count was 11 to begin with, which was now 160. We admitted with encephalopathy 14 week with ART and antifungal default, so he defaulted with fluconazole as well as ART. Restarted induction therapy for crypto. A repeat viral load was 98,000 copies and an updated genotype revealed the M184B mutation. Any significance of this?
Can you just show us what was this initial regimen?
Initial
regimen with which is stopped?
Bictegravir, ampicillin, and TAF.
Clearly he has defaulted on his ART and now I think he started activating the mutation.
So CD4 has increased despite the default.
The viral load is still, yeah, again, sure.
11 weeks, only 11 weeks.
Yeah,
First
it
of
went
all-
up to.
But before we defaulted, CD4 started increasing, no?
CD4 is still on lower side.
Yeah, and the viral load from 30,000 went up to again 98,000.
So one thing is, when was the resistance testing done? The patient is defaulted, you need to do the resistance testing within 4 weeks of discontinuing an antiviral. So you'll not be able to pick up all the mutations very away. But if you have the 184V, it is there. That is a 3TC or FTC resistance. That is very clear. He has previous history of L74V as well. So now those two mutations you have. If you see those mutations, it is there. If you don't see it, doesn't mean that it's not there. And that is one important principle. The second is the discordance between viral load emergence and the CD4 going down. It's not normal. And it will take some time before the CD4 starts falling again when the viral load comes out. So essentially, I don't think it should be an issue.
Actually, it should have been on a blood pressure to show the real, mutations. So basically, this is just for the audience and what is significance of this M184 IV and M mutation. The resistance test has detected a mixed population of M184I. These changes signal emerging resistance affecting the 3TC, that is amyloidine first as a result of low genetic back to resistance of this drug. Also confers resistance to 3TC and emtricitabine, and also confer low level resistance to abacavir and DDI, which I have managed in my practice. But in isolation, do not appear to compromise clinical responses to these drugs. At week 20, it was restarted, but again defaulted, and receives counseling and psychiatric medication for 8 weeks. Bictegravir, emtricitabine, and TAF was resumed at week 31. At a follow-up of next week 37, he had a HIV viral load of 14,000 copies and a newly acquired R263K mutation. So basically, I wanted to bring this case because we have moved far away from efavirenz-based regimen. Still, we are using it from nevirapine and all PIs and all that, and everybody is using integrase inhibitors. So I thought of bringing this case from a journey, and it's not my own case. But I thought I should bring this case because of the usage of integrase inhibitor and how do we do that. So what's the significance of this R263K mutation?
Okay, so this is first of all, this is quite surprising. I don't know. This case, guys also got this case from somebody. So the problem is, it's very rare if you fail INSTI based regimen to develop INSTI resistance. You may develop a TTC, you may develop the backbone nucleoside. It's very rare in a naive patients to develop. That means there is a problem with functional monotherapy with Tegravir, etc. or PTG. Since that is available in a fixed dose combination only, it's unlikely that we will only take Tegravir and not. So this is a little unusual. But 263K is an integrase mutation. It's basically selected either by TTG or Tegravir in naive patients. Integrase mutations have two different pathways. So 263K in naive patient with another G188 as 145, 48, 155. G, but this R263K only reduces dolutegravir or Tegravir efficacy with 2. So it's not a very powerful mutation. So there is no clinical evidence for this, but some people can double the dose. If you develop it on DPG, you can double the dose of DPG PD and maybe get away with this. But other mutations into CG188, 118R, or if you have in DPG resistance, the rule of thumb is if you have 2 to 3 mutations, it reduces the activity 2 to 3 fold. If you have more than 3 mutations, and particularly 148 and 155 pathway, then you will have 12 to 15 fold reduction in the activity. So the real issue is whether you can get away by doubling the dose or straight away go for PM.
So I think the whole idea of bringing this case was because we are going to maybe in next 5 years time, possibly or 3 to 5 years time, we may start seeing this type of resistance, either patients defaulting or not, or people who are not taking the medication properly. So possibly, so I think just to make the awareness about R263K, what was. So basically, just integrase inhibitor which include Atacavir, Altegravir, Linoxidil, Dolutegravir, and Bictegravir. One of the newest class. Resistance to Atacavir and Altegravir have been well characterized in the literature. And as Dr. Pujari said, that yes, if you have these N155, 48 or 140, 48 pathways, then it causes a high level resistance to Atacavir and possibly Bictegravir and Dolutegravir also. The second generation, like Dolutegravir and Bictegravir, have high values of resistance and possibly even if you have a single mutation, possibly you may not. But so I think what would be that in case you would have these additional mutations like 155 and 148 and all that, possibly what would you do where you have a real resistance to.
So we can see here threefold with the R263K, but when you have this 148 with 155, it reduces activity of DTG by 15-fold. So even if you double the dose of DTG in the context of this, it is not going to work. You see, this is still emerging. There's not much very concrete data, resistance very rare with the integrase inhibitor. But there are two distinct pathways. One is if you have a naive patient whom you give an integrase inhibitor, the resistance pathway is predominantly 263K and G118R. And if you are INSTI resistant like Rantegravir in the past, and you have some INSTI resistance, you're already on DTG, then you get 148, 155, 143, then I think there is 97 and 138. So these are the point mutations. More number of mutations, more reduction necessary.
And also, I think though I heard you talking about the DTGs being such a like 50, you said about the 50 milligram is quite a good dose, and possibly your 10 milligram, and that would have been equally good. And so whenever we use comparison, we use double dose of Dolutegravir here. So that could that be a reason also to in future those who are not using double dose of Dolutegravir when you have a rifampicin or rifabutin based regimen, would that emerge into a resistance over a period of time?
So there is one data from Africa which they use DTG OD. It's not a randomized trial with rifampicin in part of routine care, and they saw good virologic suppression rates. There are two different distinct scenarios. One is I'm already on DTG and I'm virologically suppressed, and then I develop fever, and then I give rifampicin, you may later will get the TB because you're already suppressed. But if I'm not initiating, I have TB first, and then I initiate the TB. Then in that context, maybe it's a problem. Right now, the guideline is clear.
Right, so I think I just thought of bringing this drug because everybody is using only the integrase inhibitors in our clinical practice.
Question rather than comment, I would say.
Yeah.
Like, because with the newer space, to develop resistance with such sporadic default, even with a partially working backbone, is little unusual. So whether these guy may be having more than 3 tabs or something before which made the backbone itself compromised and they were not detected in the testing because he's on a tenofovir-based regimen now.
So even that doesn't matter for integrase inhibitors. So now we have this Nadia trial that I showed you, and there's one other recent trial which was presented at CROI this year, where they showed that even if you recycle the nucleosides, and they actually had subgroup analysis where they showed if you are TDF resistant and you are using TDF, you are still active. So I think this is an unusual case because there is no chance for this guy to split this tablet and take it. I mean, you can't change the entire casing and take it away. This will happen only in the context of monotherapy, mostly.
So do we need to change backbone or if we are suspecting multiple tabs
I think we need to work on this adherence first.
That is true, but if we have to offer something, what should
Now
we
he is having the 263A, there are 2 options. Either you can try DTG or best way is to push him on a darunavir. He's never been exposed to it.
with same backbone?
And you can keep the same backbone. In the Nadia trial, they compared it with 2x2 factorial design. So they compared darunavir versus DTG also. With, without recycling nucleosides on similar design. So here, of course, you would prefer TAF with darunavir.
How much of adherence is required for the sticky drugs like this? Like how forgiving are these drugs?
I don't know, I have not come across adherence rates for it, just as we had for NNRGI or PI. I'm not sure I have come across, maybe somebody has come across what is the exact adherence rate for activity. Because even if you take it alternate day or something like that, with the backbones, you will unlikely develop instant resistance. You will develop 184, you will develop TDF.
Now
You
that
see
we
in the
have
regimen.
only 2 drugs.
DTC, 3TC.
Yeah.
So only 3TC, if you fail, even in that study, they didn't have. In Gemini 1 and 2, virologic failures, they didn't show resistance. So this was mostly non-adherent. And DTG, 3TC again is a fixed dose combination tablet. So what is available in India? It's unlikely that you will use only 3TC or only 3TG monotherapy in this context. So it's very, very rare. You see really integrase inhibitors, especially in naive patients. If you have fast air, altogether will die, and you are giving 2TG, maybe that's a problem. Because your OBR may not be completely good. Maybe faster to giving functional benefit.
And also, I think regarding the adherence with earlier there was a problem with nevirapine because you had to take twice a day and forwarding because of the neuropsychiatric and so on. I think once integrase inhibitor, we hardly see anybody dropping the adherence is almost close to, I think whatever my clinical practice it's close to 100%, I would say. Though we are not measured it, earlier we used to in effort in the case we used to keep a track of what is happening. But I think with IG things are completely revolutionary.
It's not just a question of side effects, taking
Yeah,
drugs lifelong and preventing. So in that case, like if the adherence is poor, so there are no studies saying that okay, this much of adherence is okay for that.
Yeah, I'm not sure. I'm not sure. I don't know. But again, if you fail, you're unlikely to fail with resistance. And if you have resistance, you'll have it for the background.
So this is like just to recollect what that very already said. Whatever advantage and disadvantages of the therapy versus bictegravir, and which patient would you switch to bictegravir and which, what about TAF and TDF? I think you already mentioned about it also. Any comments on?
At least, at least whatever bictegravir I have used in a couple of patients, I had seen, strokes, increased risk of stroke, so almost stopped, using that. With dolutegravir, as I mentioned, we do all those changes in dosage pattern, especially if you are giving with certain other drugs like rifampicin, etc. But apart from that, I just wanted to ask in the same context, like even in future, if you see these kind of patients failing on the INSTI, are there any other options like to treat these kind of patients, like injectables?
If you fail integrase inhibitor, it will be first line. And if you develop at least, you move to darunavir, the post-trade protease inhibitor will do. And there is cross resistance between DTG, bictegravir, and cabotegravir. And cabotegravir is only used in the context of suppression as maintenance.
So from the weight gain, I think weight gain was a major issue with dolutegravir, which we see around 10% of the people with dolutegravir and 60% with bictegravir. And possibly with bictegravir, it could be possibly the TAF, because TAF is known to cause potential enhancing the weight gain. Could that be the reason, Sanjay? Because bictegravir is always with TAF, it's only with agent. So
No, if you compare the 4 drugs in states, are higher weight gain as compared to PNs and amongst the states, dolutegravir and bictegravir are similar. Elbetagravir, potisistat, zaltegravir are those are first generation states we don't use it. So DTG, bictegravir is similar. Amongst the NRTIs, TAF is the worst. The theory now is that we don't know why weight gain happens or why less weight gain happens with TDF and ectropions. So there is a theory that maybe TDF and ectropions have weight suppressing effect, and you are returned to health is one theory. The other thing is newer ARVs are tolerable, better GI tolerable. So you eat more, because you are tolerating the drugs. So that is why you have a weight gain. And then there is fancy theory of melanin, appetite. So those things we really don't know. The other important thing is in the SALSA study. The SALSA study actually looked at from a 3-drug ARV randomized to DTG versus TAF plus. And they showed that if you are switching from TDF to DTG in your initial regimen, you are actually gaining weight. But if you are switching from TAF to DTG, you cannot gain as much. So essentially, the weight suppressive effect of TDF. So those theories are coming in. We don't know. Also, we don't know the clinical consequences of this weight. Apart from, of course, looking back.
Apart from, I think, weight gain, another issue with TAF and TDF was the bone issue, which is much lesser with TAF compared to so even another. I think there are 3 things Sanjay we are discussing. One is the weight gain, second is the bone, and third is the renal issues between the TDF and TAF. I think these 3 issues which come into the clinical practice. And what I think this was even the renal tubular effect and the renal discontinuation events were much more with TDF compared to the TAF. And so I think TAF have more stable blood and plasma pharmacokinetic profile, has shown a more favorable pharmacological profile and a higher antiviral activity. Due to lower circulating levels of tenofovir, that is, I think maximum goes in the cell and less is available in the circulation. So TAF minimizes short and long-term impact on estimated creatinine clearance, renal tubular proteinuria, bone mineral density, and in fact, in one of these studies, showed that if you switch from TDF to TAF, if your creatinine clearance is between 60 to 90, your creatinine clearance improves by around 2 ml per minute. If If it is between 30 to 60, it improves by around 5 to 6 ml per minute. If you switch over from TDF to TAF. This is another slide which again shows the efficacy and safety of TAF versus tenofovir, where your renal clearance and your GFR and your again proteinuria decreases. So coming to the next case, and this is an older case. This 55 years female, she was admitted with me, diagnosed HIV December 2016. She was on D40, 3TC and nevirapine level. So this is a patient in Leelavati, admitted outside with acute abdominal pain, diagnosed with pancreatitis in May 2017, admitted in, and she had stopped the regimen because of the abdominal pain because of pancreatitis, and she was admitted with severe bilateral edema of feet and severely teared back. The liver was huge and large, and she came to us almost after 8 weeks, so 4 to 8 weeks of stopping ART. The viral load when she came was less than detectable, and the CD4 was 354. So UAG showed severe hepatomegaly with no IHBR dilatation, severe fatty liver with no IHBR dilatation, mild pancreatitis. Bilirubin was 2.9 and admission. It is almost again 4 to 6 weeks of stopping the therapy. The liver enzymes were borderline, and the CBC was normal. And if you see then over a period of time, the bilirubin from 2 went up to 4, 5, 9, 10, and this. So finally, we wanted to know what's going on and what could be the differentials on this patient. So liver biopsy was done on 20/06/2017. So what could have been the possibilities in this patient? Could have been a HIV cholangio, just a differential discussion. What do you think about this? Stopping steroid and still the hyperbilirubinemia continues. And she comes with almost like a cirrhotic, almost bilateral edema of feet, grossly, and it's completely NSR. She has a severe NSR production. So we thought of whether it's HIV cholangiopathy, sclerosing cholangitis of HIV, or could it be drug-induced liver injury, or it could be an acute liver injury. And this is the liver biopsy what we did. The left hand side shows a normal liver, and you can see this patient's liver biopsy, which is completely packed with the liver fat. So just your comments and your experience about standing, So standing, this was the case which I saw, and we went at the liver biopsy because we not knowing what was happening to this patient. So
no, the issue about NFLD is coming back again in HIV therapeutics because of this. It still is causing weight gain, causing attack, causing a lot of hypertriglyceridemia and lipid abnormalities. So NFLD is something which needs to be screened for along with other comorbidities, even in the modern ART. I think there is a change in terminology now. They call it as MAFLD. So in the hepatology circles, they now don't call it NFLD. They call it metabolic disorder associated fatty liver disease. So it's basically a diagnosis of inclusion rather than NFLD being a diagnosis of exclusion. So I don't know. Statins, and honestly, I have not used much in the last so many years.
okay. I think stavudine hepatotoxicity, I just went to that during that literature. Hepatotoxicity due to stavudine and usually marked by lactic acidosis, marked hepatic steatosis. This was, I think, this microvascular fat which this patient had. And this form of liver injury, actually, I will be wondering why it came after, stop for 4 to 6 weeks and still the problem continued. And I think when we went to the literature, it can come almost even after 2 to 6 months of stopping the stavudine therapy. And that's why we were perfect with this case. But finally, we just gave it up, and then I think she is on rapid based regimen and she was doing extremely well. So coming to the next topic, which again I thought one is to discuss about dolutegravir, because that is what I'm doing. The next topic I thought was discussing about HIV and transplantation, because now I'll tell you the reason why I want to discuss this topic about, because transplantation in HIV, organ transplantation is a treatment of choice for advanced organ failure. Previously, HIV was considered an absolute contraindication for transplantation. Exclusion has been based on the following concerns: immunosuppression medication, accelerating the progression of AIDS, increased morbidity and death. And transplantation in HIV was felt to have increased mortality and was a waste of viable organs. That is what it was thought of. But the reality is that advances in HIV therapy and survival in heart era is now similar to other chronic diseases. With increased survival of HIV patients may now experience advanced stages of other illness and end-stage renal disease requiring dialysis, end-stage liver disease like what we have in fatty liver, advanced heart failure, advanced lung disease due to from various etiologies. Like I think HIV with this integrated regimen and the newer regimens, they live as normal and they would develop the same comorbidities as what a non-HIV person would develop. And I think it's time that we all, and we in global, we have transplanted not only in a HIV positive patient, but from HIV to HIV also. So the comorbidities in HIV were heart has decreased HIV related mortality because HIV accelerates HCV and HPV infection. End-stage liver disease is now significant cause of mortality in HIV patients because of the HCV and which they could have. Renal disease is increased demand for kidney transplantation due to renal failure from complications associated with event and other issues. So I just come to a case. She is seropositive, autosomal dominant, focal stage. This case was from Global Hospital, Mumbai. Undetectable viral load CD4 count was more than 200, and she was doing extremely well. And she was on a 10-4-week FTC efavirenz based regimen where she was virologically as well as immunologically she was doing very well. So the next question, the patient was referred to me, and does the patient require a change in therapy, or do we continue same? I think it's an era of transplantation, and I think the it's as good as non-HIV. HIV should be considered as non-HIV with the robust antiretroviral therapy which we have, and I think we should be knowing about antiretroviral therapy because we will be taking referrals for solid organ transplantation. So does she require any change in? Is she doing retinal transplant?
Of course, I think TDF is one of the issue. So there maybe we can think of changing it. Apart from that, drug-to-drug interactions post transplantation, whatever immunosuppression she is going to get, like steroids, that drug-to-drug interactions will seen, especially with the father and steroids.
So ART was changed to lamivudine abacavir, as Mahesh said, we changed it to after doing HLP 5701, the 10-4 was changed to abacavir and abacavir. The donor was also HIV, and the patient was also doing very well. I think we will change the ART in that. But is there a chart which says that NNRT has much drug interactions with the immunosuppressant, microphenotype which doesn't have, but this calcineurin, tacrolimus, tacrosporin, it does have a lot of drug interaction, especially the NRTS. Whereas the integrase inhibitor, so the last column does not have any drug interaction. So I think those people are going, especially for renal transplant or liver transplant, especially renal transplant, we have to take care of the tenofovir. Otherwise, for all the organ transplants, I think possibly efavirenz may have to be changed to integrase inhibitor. So that is what about this case. And this patient did very well after doing this. And I think I'm not going to this criteria for transplantation donor that you require a CD4 of more than 200, and the donor if is HIV positive, then you require a CD4 of more than 500. I think I'll stop here. There's one more case, but I'll stop here.
Only one comment, sir. In the first case, the flu cytosine which was given associated with beta-globin and other things, there are case reports in literature. The flu cytosine TAF interaction reduces tenofovir level by 90%. So then it can act as a monotherapy, and then you can have this type, the similar type of mutations were seen in that case also. Both the mutations were present. So flu cytosine, the associated drug interaction will have developed.
No, it was later on. It was introduced later on, subsequently. It is a point to be taken that possibly 5-flu cytosine and tenofovir has a drug interactions.
There is one proposal that since we began a little late and it's sometime we are overshot, can we have Dr. Rupanjan's lecture tomorrow at 9:30? so that we can begin at 9:30 instead of 10 o'clock.
Yes.
Let's see what everyone thinks.
Yes.
Yes, yes.
Because he was trying to say, I will shorten my presentation and run fast and all that. So I said, nothing doing. You have come all the way from Siliguri. And so Siliguri time is 10 o'clock. So I think we will begin tomorrow with that as the first lecture. Everyone agrees?
Yes, yes.
Okay.
Thank you. So we go on to the next panel, which is challenging cases in OIs. For this, I'd like to call Dr. Aisha Sunawala as the presenter, consultant infectious diseases at Anuja Hospital, and as our panelist, Dr. Vinay Kulkarni, HIV consultant at dermatology at Prayas Amrita Clinic, Dr. Deepanjan Hardwardhan sir, head of the Department of Medicine, and Dr. Geetu Jo, consultant microbiology at Jupiter Hospital, Dr. Tanu Singh and Dr. Vasant Nayak.
Okay, so good evening, and it's been a long day for all of us. After this long break, coming back to school, so to say, from the virtual world. So these cases are a little more pictorial, so I hope they wake us up and we're a little more sort of excited about them. But the opportunities really are myriad still, and they're like sort of peeling layers of an onion when you see an interesting case like this. You never know what you're going to find. And clearly, as I said, there's still ample opportunity for the opportunists. We have an appetite for these because they teach us so much. It's like piecing the jigsaw together. Sorry, I haven't put my slide. Okay, so ultimately, it's all in the story. It's about separating the grain from the chaff. It's about appreciating and understanding the blunders of empiricism, the ingenuity of IDS, and how innovative and deceptive it can be. And then finally, about protocol versus practicality when you come down to the patients, and versatility in management of these opportunities. With that, I'm going to start with my first case. So this is a young man from Patna. He's unmarried. He's an engineer who studied in Rourkela, Odisha. Do we need it to come on that screen? Can it come on that screen? No. Oh, it's not. Okay. So, December 2020, he developed fever, abdominal pain, and weight loss of 10 kgs. His ultrasound showed multiple mesenteric lymph nodes, and he was started on empiric first line AKT in Patna. Jan 2021, there was no clinical improvement. In fact, he had developed AKT-induced hepatitis. He was found to have oral candidiasis at this time, and somebody tested him for HIV, and the AKT was modified and continued. This is a picture shared by his brother at that time. When they first noticed these non-pruritic, painless, reddish-brown patches which appeared on his skin soon after. At this time, he had severe hepatitis and he was hospitalized. His AKT was interrupted multiple times, it was modified, and the ART was deferred because they were not able to establish an effective AKT regimen. CD4 at the time was 94, less than 100, 9.3%, and an HIV viral load was not done. April 2021, he was finally started on TDF-3TC DTG, double dose of DTG because he was on anti-tubercular treatment at the ART center in Patna. He had marked clinical improvement in terms of fever and weight gain after starting the ART, but the skin lesions progressively increased. You can see how they've developed on the nape of the neck. September, October, his CD4 had gone up from 94 to 383. However, he started developing recurrence of abdominal pain at this time, vomiting, anorexia. He also had dysphagia for solid foods, regurgitation. He also developed a swelling on his palate. And once again, weight loss of about 5 kgs. So what are our keywords in this case? I mean, we've been through a lot of it. He lives in Patna, he studied in Rourkela, fever, abdominal lymphadenopathy, which is what the disease began with. Subsequently developed pigmented skin lesions which are progressing on antiretroviral treatment. He's developed a palatal lesion. He has dysphagia, vomiting, abdominal pain, new weight loss, and he had initial clinical improvement on the antiretrovirals for a couple of months. So that brings us to the eternal O versus H predicament. Are we talking about a single opportunistic pathogen here? Or are we talking about multiple things in this immunosuppressed patient? We know he's HIV positive. Is there TB really? What about the opportunistic mucocutaneous condition, which is paradoxically worsening on antiretrovirals? What is this new GI condition? So can everything be explained by a single opportunistic infection here? Anyone wants to take a go at that? Audience members? Sure, Dr. Nia.
Oh, I remember the law of parsimony which sir had mentioned it to me. But in this particular case, there are a couple of key points, which is the epidemiology from where it's coming from. Then there is hepatitis, which you mentioned earlier as well. So
after he started the anti-tubercular treatment.
Okay. So if you talk about one OI, then it can be explained with histoplasmosis. There can also be possibility of leishmaniasis as well. I think this is something which to my mind is coming first. And of course there can be multiple OIs also, but I think histoplasmosis is
something strongly to be kept in mind. Absolutely. Anybody else on the panel?
So one is for saying we do not have a so for saying tuberculosis, we do not have a proof to say that this is tuberculosis. I don't think the lymph node biopsy was done in this patient. Correct. Empirically.
The nodes decrease with it.
That was the checked subject.
And second thing is, whenever we see a paroxysmal worsening on ART, we have to prove that this patient has got tuberculosis. Only then we can say that this paradoxical worsening. Because whenever you say iris, it is always proven. It could be proven or probable, but usually we always say proven. and especially with this palatal ulcer and then lymph nodes and coming from Patna. I think I agree with Neha that we have to look. What was the CBC count? Cell count, CBC. So I think we have to look at. We have, meaning whatever it is, whether it's a lymphoma or whether it's histoplasmosis or it's TB. I think we'll have to have a whenever a patient put on AKTF is not doing well, we'll have to have a histopathological diagnosis for that.
So I think right from the beginning, the approach was incorrect. So when he was diagnosed with TB, there should have been an effort to make some kind of diagnosis, which didn't happen. He was not tested for HIV at that time, which is a prerequisite. When you are diagnosed with TB, you have to be tested for HIV. Anyway, after starting anti-TB drugs, he got AKT-induced hepatitis, but he really didn't improve very well. No. His skin lesions didn't improve. So I would not think of tuberculosis here.
The improvement was only transient after the antiretrovirals were started.
Yeah, so I think the antiretrovirals caused improvement in whatever illness was because of the HIV, because of the virus. But here we have an opportunistic infection which has actually not been treated or maybe treated partially. So we are looking at a low virulence pathogen here because he has gone on for 7-8 months with this. So I would think of a variety of differentials. I would think of MAC because though his CD4 was 93, but he had weight loss, he had fever, he had mesenteric adenopathy. Yeah, and partial, and some of the anti-TB drugs also work against MAC. So maybe that is why it kept on, there. So that is one possibility. Because he's from that area, I'm not sure of leishmaniasis because as I understand, he was not from a rural area, he was from an urban area. But yeah, and did he have massive hepatosplenomegaly? No. So that would make leishmaniasis less likely. So MAC, histoplasmosis, CMV, cryptococcosis disseminated, something like that.
Now, do we have any biochemistry reports?
Like
Granulomatous hepatitis is a possibility, whatever be the etiology. So the enzymes will tell us something, typically later.
So at this time, this is how he presented to us. And whatever I've shown you are the sort of remarkable investigations. Everything else, nothing else was really worked out.
But you've not shown any of the results of the investigations, meaning except
that they were unremarkable. I mean, apart from having transaminitis, whatever was done over there was unremarkable.
So
except for the skin biopsy.
The result of the skin biopsy.
That's right. Okay. So if we were to approach this case of HIV-associated dermatosis, we know that etiologically we have practically every possible thing: bacterial, fungal, viral, parasitic, as well as others. By morphology, these would be papules, nodules. So molluscum clearly doesn't look like molluscum, condylomata, verruca. Bacillary angiomatosis, endemic mycosis, as was pointed out, Kaposi sarcoma. And if we look at his baseline CD4 count, again, some of these are repeated over here. Dr. Tanu pointed out MTM, MAC as well. So it was in November 2021 that he was finally referred to us from Tata Memorial Hospital with a diagnosis of cutaneous Kaposi sarcoma, which was diagnosed on the skin biopsy earlier in Patna and then reviewed by them, and they confirmed that this was a Kaposi. And they referred to us for fitness for chemotherapy. Clearly, they had only done the skin biopsy at that time, and they referred to us because he had these ongoing complaints of abdominal pain, nausea, anorexia, dysphagia, and weight loss of more than 5 kgs. This is how he looked when he came to us.
Can you just take a few slides back? The first picture.
Sure. Which one? The first
one? The first one who is sitting.
Sure. So,
yeah, if you show me that lesion on the leg, my first diagnosis would be Kaposi.
This one?
Yeah.
Okay. Why would that be?
That's because I've seen a 4 or 5. They look like that blackish, violaceous papules. Plants. That would be my first diagnosis. Because this is opportunistic infections kind of a thing.
So does the location also make it more probable?
Yeah.
Also the oral cavity, also the intestinal.
Palatal thing which he
Palatal
developed
thing.
subsequently.
Yeah, I mean, if that is the thing you asked me, it is the question.
So going back to where we are now, so clearly you can see how much it's progressed from there. I mean, this man cannot even open his eyes. You can see how it's coalesced on the face. That is the lesion on the palate. Can you see? Frond-like sort of lesion on the palate. And again, coalescing and edema, induration on the thigh. So PET scan was done for this patient. And there was pickup on the palatal lesion. There was some pickup in the spleen. There was pickup in various lymph nodes. And the nuclear medicine person actually pointed out to us, we had her review it at our center. These were all done before he came to us. But when she reviewed it for us, she said, if you can see, there is complete sort of uptake, metabolic uptake all along the skin and soft tissue of the face and even sort of, around the trunk and everything. He also had bilateral enlarged axillary lymph nodes, which I don't have a picture of over here, with increased metabolic uptake. And you can see that there is a left suprarenal uptake as well in the adrenal. He also had discrete pulmonary nodules with surrounding GGOs, but there was no real metabolic uptake on these. So we did a further workup, including his baseline HIV workup, and we found that he was VDRL TPHA positive as well. He had a positive serum beta-D glucan of 197, and again we did this, because we were also worried about endemic mycosis and all. Transaminitis was ongoing, but he was still on anti-tubercular treatment. His HIV viral load done for the first time was 263. We don't have a baseline. So we asked for a USG-guided axillary lymph node biopsy and an endoscopy. The question is, are we dealing with just a cutaneous Kaposi sarcoma, or is this an extracutaneous Kaposi, or is there something else going on as well? Which is why we wanted to probe deeper. So we tried to biopsy further. So this is what our endoscopy showed us. And he had all those symptoms of dysphagia and anorexia, weight loss. So you can see here in the esophagus and the gastroesophageal junction, sort of these nodular lesions over here, friable nodular lesions. This is in the first part of the duodenum, similar lesions. So we have HIV, we have this query thing of TB, syphilis, query stage. Disseminated invasive mold infection because the beta-D glucan is raised, these lesions on the skin, but clearly they've been proved to be Kaposi. We don't know what's going on in the gut. We have GI involvement. So is this extracutaneous Kaposi sarcoma? Is there an additional unmasking opportunistic condition that is ongoing?
We have to look at Kaposi, but we also require to rule out another opportunity, especially the adrenal gland being involved.
Absolutely. That's something that alerted us that there's a suprarenal
or something. Right. And Kaposi sarcoma is known to be associated with complete infertility as well as extra. You can have difference in axilla, endometrium, and all. I've seen that the diagnosis many times Kaposi will come on the lymph axis.
Yeah, so it looks like there's something else also happening in this patient because of that. And if you're saying adrenal enlargement, GI ulceration in that area, then I think histoplasma would be the first of the cards. Okay.
Regarding syphilis, I think it could be late syphilis because.
You think it could be late stage?
Unless you do a CSF, that's the only indication to do a CSF is when you have a TPH and VDRL positive in a HIV positive patient. You have to rule out asymptomatic syphilis, but that happens only in HIV, whereas in a normal phase, a immunocompetent person possibly will not do it. Yeah.
I can't recall, ma'am. We had done it, but I can't recall of this.
Maybe if it's negative or it's low, and PTH positive, we just pass syphilis as well.
Right. He wasn't with us. He would
would just come to us and he was at Tata. So, and there was a lot happening very quickly, but we come to it. We come to it.
I would rather, when the person comes and we are shown two pictures, I would to take two biopsies. One is on the leg, probably would show Kaposi sarcoma. The one on the neck, I don't think it looks like Kaposi.
Okay.
At that level, I think there is something different in that, which could be histoplasma. Now, both things can happen together because we have lymphomas who are kind of having immune deficiency and then coming up with molluscum-like lesions and turn out to be histoplasma and disseminated histoplasma. So probably right from there, I think we should have been a bit more inquisitive. Just looking at the skin, probably we would have got two things because probably the Kaposi is spreading so rapidly. Now treating histoplasma, which also probably because of the immunodeficiency has gone too wide disseminated. The symptoms wise, and I think the things are not explained by syphilis kind of a thing.
Okay.
Yes.
So as I said, there was a sort of urgency to evaluate this patient because they had already diagnosed cutaneous Kaposi. They wanted to start this patient on chemo. And we had to select two sites. We selected an axillary lymph node and we selected the biopsies from the endoscopy. So if we were to look at a quick recap of Kaposi, this is Moritz Kaposi who first sort of worked with and identified the idiopathic multiple pigmented sarcoma as he called it. And he saw it first in its classic form in elderly Mediterranean men as lesions, as I just described, on the lower extremities, predominantly restricted to cutaneous lesions. Later, endemic African form was seen in children with generalized lymphadenopathy, and subsequently the immunosuppressed variants in HIV and iatrogenic immunosuppression were discovered with visceral involvement as well. And we know that the organism responsible is HHV8. The seropositivity of this varies worldwide, as you can see from this data over here. Study from North India showing us that there's a 26% seroprevalence in young ART-naive HIV positive men. And we know that male homosexuals have a 5 to 10-fold increased risk. We also understand that the prevalence of Kaposi sarcoma mirrors the HHV8 seropositivity rate in a population, which is why in the Central African Republic, where there's a very high sort of seroprevalence, there's a strong predilection in the pediatric population. So if we were to stage this by the TIS staging, our patient has a tumor which is now associated with edema, as you could see on the face, the thigh, very gastrointestinal involvement. He had a low baseline CD4 count, less than 200 for sure, and there are these symptoms as well. So clearly he comes into the poor risk. Now, as per the differentials that have been discussed, some more that have been discussed by the panelists here, but clearly Kaposi snugly fits into all these variables that the patient had: skin fat folds, oral, lymphadenopathy, pulmonary nodules, GI tract involvement, anecdotal case reports of the adrenal mass, liver dysfunction with Kaposi iris possible, but clearly positive beta-D-glucan and VDR and TPHE don't. What about syphilis? Again, these lesions are not typical, but still some of the things can be explained by syphilis. Histoplasmosis fits in again, makes almost a near sort of complete match over here. What about chalanomycosis or emergomycosis? There are reported cases from Bihar, very few, not as much as they see in the Northeast, but has been reported. MTB on AKT really, as everybody's pointed out, that this diagnosis seems less and less likely in this patient. Leishmaniasis, skin plaques, nodules in immunocompromised patients with post-Kala-azar dermal can be, similar to this. I don't know if anyone has more experience with this, from where you all are, but I have very little knowledge, clinical experience with leishmaniasis. Bacillary anthromatosis is another one, but that could fit into some of these things, and what one needs to consider in patients with HIV who have nodular plaque-like lesions. And finally, pneumocystis is also mentioned as an important differential in patients with these kind of skin lesions, but clearly nothing else really fit in apart from the positive beta D glucan and those pulmonary nodules, TGOs. This patient had no real respiratory symptoms. Okay, so
just a comment.
Sure.
Leishmaniasis, PKD-LBD. The lymphadenopathy part doesn't fit in. And you asked for splenomegaly, someone asked, so that was also not there.
Right, not there.
Otherwise, Patna is a very hotbed for
Very hot.
leishmaniasis. So, except for the skin lesions and maybe the oral ulcers, the rest of the story doesn't actually fit
And
into
no
leishmaniasis.
cytopenias or
No
anything as you pointed out. So, does anyone know why I'm sort of showing this picture or what it may be? Umang is laughing at me because he's been through this before. So basically, it's a high point of land or rock that is projecting into the sea or any other water beyond the coastline. Yeah, it's a nice romantic picture. Sorry? Absolutely. See, there's somebody who knows what it is. Well done. So that's your promontory sign. Okay. So clearly, very few of us here in the generation that has actually seen Kaposi. So this is the promontory sign, and these lesions are basically, when you see the histopathology of Kaposi sarcoma, there are two major abnormalities that you see. One is whorls of spindle-shaped cells with this, can you see these spindle-shaped abnormal cells almost in fascicles, in whorls? You can see these elongated nuclei within them. They're all sort of abnormal. And you see neovascularization with this aberrant proliferation of small vessels. And this is typically called the promontory sign in Kaposi sarcoma. So again, another spindle cell proliferation, your promontory sign, and this is your immunohistochemistry showing you uptake of the KSHV nuclear antigen, which stains brown in the nuclei of the spindle cells. So this was our lymph node biopsy from the axillary lymph node, again showing you the spindle-shaped cells, the fascicles of spindle-shaped cells, and these abnormal sort of vascular spaces with red blood cells within them, okay, which is typical of Kaposi, and it was diagnosed as Kaposi sarcoma. And this is the biopsy from the first part of D2, showing blunting of the villi and again spindle-shaped cells arranged in these fascicles, mild nuclear atypia. Again, Kaposi is associated with very mild nuclear atypia, nothing very significant. And we also had the immunohistochemistry showing you positive staining on CD34, CD31, and a proliferation index of 20%. Anything more than 10% is sort of significant. So now we have a patient with disseminated Kaposi sarcoma who has paradoxically worsened on antiretroviral treatment. At this point, I stopped the anti-tubercular treatment. It was almost a year into treatment anyway. He completed 14 days of ceftriaxone for syphilis at Tata itself. And we started him, he was due for chemotherapy. We didn't know what was going on with that positive beta D glucan. We wanted to repeat it in some time, but we started him on empiric posaconazole because we couldn't be certain that there was no other endemic mycosis or anything that was going on. He completed the first course of chemotherapy. What do we know about Kaposi sarcoma iris? Both paradoxical and unmasking iris has been described in patients on heart. It's defined as any more than two of the following: an abrupt increase in the number of Kaposi lesions, or appearance or exacerbation of lung opacities or lymphedema with an increase in the CD4 T cell count, which he had. We don't know his baseline value. Lung involvement, thrombocytopenia are associated with what's outcomes. Now, this patient went on to complete 3 cycles of chemo. His liver functions have returned to normal, and this is how he looks now. He's doing really well. His repeat beta D glucan is negative, and we've sort of stopped the posaconazole because the chemo is now into. He's finished his induction and everything. Okay, so with that, moving on to our next case. This is a 42-year-old gentleman, sales executive, married for 10 years, no children. And he developed sudden onset blurring of vision and chemosis of the right eye. He has no other complaints. He consulted an ophthalmologist who diagnosed severe iridocyclitis and vitritis. And on further workup, he was found to be HIV positive. He was referred to the infectious disease specialist for this. So, anybody with differentials, iridocyclitis, vitritis, seropositive patient. Okay, so if we were to go through the spectrum of uveitis, the anterior uveitis, which would be iritis and iridocyclitis, would involve a lot of the viral infections, TB, leprosy, syphilis, lepto, Lyme's, so spirochetal, rickettsial, parasitic, as well as non-infectious. Intermediate uveitis, your pars planitis or vitritis, which this patient also had, most common cause in India, TB, leptospirosis reported from South India, and some of the non-infected causes like GIA, sarcoid. And choroiditis or retinitis, again, several of the viral infections, toxoplasmosis, syphilis, Candida toxocara, rickettsia, again described over here, SLE sarcoid. What about panuveitis? So panuveitis, vis-a-vis CMV, syphilis, TB, Candida, sarcoids, Behçet's, toxo. Now, he had no genital or oral lesions, no past history of any lesions reported, no lymphadenopathy. His CD4, baseline CD4 is over 500, 25%. He has a viral load of 1,89,000. An ophthalmic review shows panuveitis not responsive to systemic or topical steroids. However, on examination, this is what we found on his hands. So when we probed further into this, he said a few months prior, he had developed an intensely pruritic scaling rash on the hands and feet. And he consulted a dermatologist who diagnosed this as psoriasis. Now we know that scaling is minor with most papular lesions, but it can be, when we're talking about syphilis, we're looking at secondary syphilis with a rash on the palms and soles. Scaling is not something that's very profound in these, and it can actually sort of in some cases be severe enough to look like guttate psoriasis, which it was mistaken for in this case. But involvement of the palms and soles is a giveaway against psoriasis or against any other sort of dermatosis, and it distinguishes secondary syphilis from psoriasis and pityriasis and things like that. But he clearly mentioned that now this is doing absolutely fine, and this is just the remnant of it, and it's not bothering me anymore. Nevertheless, sorry?
I mean, my undergraduate training tells me that it's supposed to be non-pruritic.
Absolutely. But
So, any comment from?
Generally non-pruritic, but both psoriasis as well as syphilis should be non-pruritic. But when it comes on palms and soles, because of the site itself, many times the patients would say that it's slightly itchy. So the itching and kind of a thing, especially in palms and soles, may not be very guiding.
This is a Bushke monitor of sign.
That is the blunt edge of the needle.
So, sir, there's a series which says that almost 40% of lesions, scaling lesions that appear on the hands and feet in secondary syphilis do cause pruritus. Yeah. So this ophthalmic review showed panuveitis, which was not responsive, and here we have a positive VDRL and KPHA, and we have an RPR titer of more than 1:128. Okay, so now my questions, which again, some of us, a lot of us who sort of worked in the last or become consultants in the last 5-10 years are seeing an emergence of syphilis, but we didn't see as much during our training, and we're still learning with every case. So, first simple question: what stage of syphilis is this, and is it important to stage in this patient? Is this early syphilis, primary or secondary, or are we talking about late syphilis because he has ocular involvement?
Ocular involvement can occur at any stage, but it is important to stage because your treatment would depend on the staging. If you find that there is CNS involvement, then you will have to use drugs which have good CSF penetration. Of course, even for ocular involvement, you have to use those drugs which have good penetration in the CSF.
What is the case?
I think for this, you called me. See, one thing, yes, syphilis is tremendously on the sales, and I have published a paper, I think, that from 2001 to 2015, we have seen something like 7 or 8 cases of secondary syphilis. In 2015 to till date, I have seen more than 150. So we are seeing almost resurgence of syphilis like anything. Second thing, my friend is also there from rural Maharashtra. He is also seeing a lot of syphilis. Third thing, we are not seeing as much of primary syphilis, but a lot of secondary syphilis. Third thing is, it is more common in in men having sex with men, and probably that's because the anal or the oral syphilitic ulcers of primary syphilis are masked because they are painless. And that's why they are having those lesions but getting into secondary syphilis. PrEP is leading to a bit of concern because the STIs are on the rise. Because people are having unprotected sex with PrEP as well as with suppressed viral loads. So STIs, and we have now started seeing gonorrhea going up. So STIs is going to come back. Generally, she said at all stages, not in primary syphilis. Primary syphilis would be only a shankle. So in primary syphilis, we won't see eye lesions. It would be in the secondary syphilis and maybe tertiary syphilis, but it's rare in latent or tertiary syphilis having this kind of an involvement. So this would be an aggressive secondary syphilis in a seropositive person. And in a seropositive person, secondary syphilis, the classical category said you give only 24 lakhs of benzathine penicillin doesn't hold. In a seropositive person, you have to give more extensive course. Of course, penicillin is not available that freely right now. And in a seropositive person, ideally you should also be doing a CSF. Because whether you are seeing clinically secondary syphilis or whatever, because it could be just a secondary syphilis got better and now because of immunodeficiency you are seeing a reoccurrence of this kind of lesions, and initially there are syphilitic lesions because they were on the body asymptomatic, transient, and they have gone away. So I think we have to investigate seropositive people with syphilis very, very aggressively. And we are seeing congenital syphilis.
We're also made to understand that in the HIV population, stages can get blurred.
Yeah.
You can sort of, move between stages. Things can appear earlier. The usual time frame doesn't apply.
Yeah. So normally, if you had learned that tertiary syphilis comes about 10 to 15 years later, especially in HIV infected people who are the more immune suppressed, we can have a very aggressive transition to the tertiary stage of neurosyphilis.
So one question which always was in my mind is that do we definitely gain from doing the CSF if you are not doing a proper CSF VDR?
So I am saying that CSF VDR.
Because in
yes, when I say CSF is not routine CSF examination. In fact, as you rightly said, any HIV positive person, if you are drawing CSF, you should be looking for India Inc. also and cryptococcal antigen as well as syphilis also, because it should be.
But at least in my practice in Bombay, maybe here also, we are unable to do CSF classic VDR. They are doing something else like they are doing a trust or some other test. Now whether that is in lieu of a classic VDR is something which I don't know. So what I have been doing is to treat everybody as if he has neurosyphilis. Yeah. Because then
So we'll come to it. You justify. Okay. Now all these years I believed you, now I found evidence for it. So if we were to go by the book, okay, as they pointed out, central nervous system involvement, including ocular syphilis, can really occur as early as, Sir is saying only with secondary syphilis. Mandel says even with primary syphilis, central nervous system invasion. And Clearly, tertiary syphilis is much later. Ocular also they say over here, that ocular also can sort of progress from primary or secondary. I'm just showing you what the schema is in the textbooks. And clearly tertiary, the neurological syphilis or tertiary syphilis is the spectrum of general paresis and tabes. Now we were to talk about ocular syphilis, as has been pointed out. To begin with, the inclusion of neurosyphilis among the tertiary syndromes is technically inaccurate because not all forms of neurosyphilis occur as late disease. The CNS is invaded during the spirocheting episode of early syphilis, and neurological manifestations can occur during any stage of the disease, as Ma'am pointed out. Ocular complications may occur as part of a neurosyphilis syndrome or isolated, as in this patient. He had no other neurological manifestation. All of the structures of the eye may be involved in secondary syphilis, but primary optic atrophy is unique to late syphilis. So all your uveitis, anterior, posterior, everything can be part of your secondary syphilis except for primary optic atrophy. Cotton wool spots in an HIV patient would confuse the issue with CMV, but retinal hemorrhage is a characteristic feature of CMV and does not occur with syphilis. So just some important sort of clinical tips that I found interesting. Ocular syphilis with HIV co-infection, CNS examination is normal. How would you proceed? So we've just been discussing this. Lumbar puncture, would you assess it, treat directly as CNS syphilis, anything else? So let's see what the guidance tells us. This is 2021 CDC guidance saying that indications for CSF examination in an HIV patient with positive syphilis serology. Abnormal neurological examination, which involves cognitive dysfunction, motor, sensory, cranial nerve, or symptoms of meningitis or stroke. Ocular syphilis with cranial nerve dysfunction, or evaluation of ocular symptoms and reactive syphilis serology in the absence of ocular findings warrant a CSF examination. Ocular autosyphilis should be treated similar to neurosyphilis even if a CSF examination is absolutely normal. And if there are only isolated ocular symptoms with no cranial nerve dysfunction or other neurological abnormalities, with a reactive syphilis serology and confirmed ocular abnormalities, CSF examination is unnecessary before treatment. So this is 2021. As neurosyphilis. So you can get away without doing the CSF unless the patient has cranial nerve involvement or any other neurological dysfunction.
Even if the patient has those problems, so you're trying to rule out something else rather than confirming syphilis in CNS. That's why you won't need a CSF.
I think so, yes. I think so. Yeah, because anyway you're going to treat as a neurosyphilis for all practical purposes. So now that brings us to the million-dollar question about what do you treat with, what do we do about, is there anyone who has success with treating syphilis with penicillin? Yeah, so it's a latent syphilis. Neurosyphilis with
Yeah, so you can use procaine penicillin here because benzyl penicillin is difficult to give because it has to be given every 4 to 6 hours. 4 hours. So procaine penicillin is difficult, but you can order it on the internet because I had to
get it with probenecid.
Yeah, probenecid is also available. So you can, because you use it even for cidofovir and all, treatments, probenecid is available. So we have used procaine penicillin for treatment of neurosyphilis, but the other option is to use ceftriaxone.
Right, so I mean, most of us take the easy option. This is the CDC recommendation which goes only with our aqueous crystalline penicillin G, or alternatively, as ma'am saying, with procaine with probenecid. But the European guidelines, the recent 2020 European guidelines, give you a second-line therapy option of ceftriaxone.
Yeah, but somehow ceftriaxone is not there in the CDC guidelines at all. Yeah, they clearly say that, ceftriaxone, there's not enough data available and you have to do everything that you can to try and procure. Because this is a common problem for us when we treat congenital syphilis, because you have to use either benzyl penicillin or procaine penicillin, which are not available. So then we also use
And
ceftriaxone.
you have a protocol for giving them the test doses and things like that, because we've never used it, so for us.
So benzathine penicillin, obviously, but for benzathine penicillin, we have a protocol.
Maybe for the sake of people who would have to now use starting penicillin a lot. Benzyl penicillin, crystalline penicillin is not available. Procaine penicillin, procaine penicillin is also very difficult to get, but benzathine penicillin is relatively freely available. We give either 24 lakhs once a week into 3 weeks or 12 lakhs twice a week into 3 weeks. That's
But even for neurosyphilis.
the point is we have to use something which is penicillin because till date there hasn't been any resistance to penicillin in syphilis. So if it works, it is 100% sure, and you have to monitor. Now the ideal would be these long-acting ones, but at least you can use 6 injections, and ceftriaxone or other things really don't work. I will tell you. Doxycycline and azithromycin are very weak drugs, and only push to the wall you would use it. My protocol would be I would give at least the first injection in a hospital with a skin test of penicillin. Ask the patient to wait for a while, see that there is no anaphylaxis and kind of a thing. Once it is done, you can give it in your clinic also. There is no problem. I think my colleague is there. We have given something like 240 odd injections of benzathine penicillin last 1 year. We have got it. Keep it in the clinic so that the patient doesn't have to run from pillar to post to procure that. So we just give. It's a very cheap drug. 12 lakhs. It's just about 12 rupees, 12 and 12.5 rupees.
Can I say something? See, the grade of inflammation is very, very less. And that's why what really penetrates is a crystalline penicillin in adequate concentration. This is not like a severe inflamed pyogenic meningitis. So here there is a very big problem of reaching the CNS by giving any of the long-acting preparats.
So
you will have to use crystalline penicillin only.
So in this patient, we have to treat as CNS. So rather, maybe we could use benzathine penicillin, but I would add on ceftriaxone with with the benzathine penicillin as well, because there is clear guidance that you can't use benzathine penicillin for CNS syphilis.
Okay, so we have this new paper now, 2021 Lancet Infectious Diseases. I don't know if you come across it, but retrospective multi-study center study, again retrospective small numbers, neurosyphilis defined as a positive treponemal or non-treponemal test, either otic syphilis or ocular syphilis and or neurological symptoms with a positive CSF, BDRL or PCR and more than 5 leukocytes in the CSF cell count. So this was a definition. They had 42 patients who they tried with this ceftriaxone and 166 in the benzyl penicillin group. Primary outcome that they looked at was overall clinical response. That's proportion of patients with a complete or partial response 1 month after, little vague over there. Secondary endpoints were proportion of patients with complete response and serological response at 6 months, as well as length of hospital stay. What did they find? In the ceftriaxone group, 41 out of 42 instances of overall clinical response, that is 98% in the ceftriaxone group versus 76% in the benzyl penicillin group. A significant p-value even after propensity score weighting. Serological response at 6 months did not really differ between the two groups. However, hospital stay was shorter for patients in the ceftriaxone group. And here you can see the forest plot with a sort of trend leaning towards ceftriaxone, especially in patients with otic syphilis and patients who had fewer than 5 cells in the CSF. What are the limitations and the comments on this paper? So the proportion of patients with more than one type of neurosyphilis who were receiving systemic corticosteroid treatment or had positive CSF VDRL results were higher in the benzyl penicillin group, and this could have been a bias. Late-stage neurosyphilis like TBs, general paresis, dementia, parenchymatous lesions, and asymptomatic neurosyphilis were excluded, and this is important to mention here. And overall, patients in the benzylpenicillin group were more serious, which could result in a delayed clinical response and a longer hospital stay. So, I mean, that's the first. We still need to wait for more evidence, RCTs, but this is what I could find, which was most recent. So this patient was given ceftriaxone. Honestly, we didn't use penicillin, and he was started on antiretroviral treatment. 3 months later, you can see a 4-fold reduction in the RPR. CD4 has improved, viral load is undetectable, and he's doing well. He will come for subsequent follow-ups, and we'll see how sustained that virological response is. I'm going to quickly go through this other patient. Again, a continuation of syphilis, but a few more sort of things to discuss.
Can I just make two?
Sure.
One thing is in seropositive patients, HIV seropositive patients, we would not expect the titers to go down that rapidly.
Absolutely. We'll just come to that in this case.
Okay.
That's what I was going to discuss here. So now this is an interesting case. He's a Portuguese national. He works in Mumbai. He's unmarried. He's homosexual. He has multiple sexual partners, and he has a florid sex life. Torrid actually. Recalls receiving penicillin shot for primary syphilis at 15 years of age. He came to me with his reports from Portugal all along. Found to be HIV positive on routine screening. In 2009, he came to me in 2019, 10 years later. He's been ART naive, he's never been started on antiretrovirals. You can see a very, very sort of grumbling reduction in his CD4 over here. Percentages remain more or less the same. HIV viral load again over the past 10 years has remained, below 200, below 300, let's say. But he came to me now with a positive VDR and TPHO with a titer of 1:160 on his non-triple test. He was advised ART even in Portugal, but he's procrastinated. So where do you fit this patient in terms of his CD4s, his viral loads? What would we call him? Elite, controller, long-term non-progressor? So if we were to look at the elite controllers, they have to maintain viral loads below the limit of detection of commercial viral load assays. He would more be a viremic controller who has viral loads that are detectable but less than 2000 copies for sure. These are barely 100 to 100. He's a long-term non-progressor who maintains CD4 counts in the normal range for quite long. It's been 10 years now. But now most long-term non-progressors are actually called slow progressors because their CD4 counts eventually fall, but this happens very slowly. However, so again, just pointing out what happens. This is a normal individual, a chronic progressor. So they will have a high initial HIV viremia, which leads to widespread seeding of the sort of viral reservoirs. And then there's a partially effective CD4 T cell immune response, which brings the viral load down to plateau level until ART is initiated. In elite controllers, they have a much lower sort of viral peak to begin with, and potent immune responses that lead to markedly lower number of infected cells. And so they maintain viral loads below the detection limit. Quite similar to what would happen in an acutely infected patient with early intervention. So these are almost like a functional cure that goes on in there. So what is correct about controllers? This used to be one of Sir's favorite questions, but I've modified it a bit in 2022. Some elite controllers may be infected with a defective or replication incompetent virus. Majority of pro-viruses in elite controllers exist in what they call a locked and blocked state. Hence, minimal viral replication occurs in these subjects. ART is recommended in elite controllers due to low viral replication and an ongoing pro-inflammatory state, or all of the above. Anyone? So all are correct. Some elite controllers may be infected with a defective virus. Initially it was thought that no, full genome sequencing of HIV isolates from these elite controllers showed no evidence of deletions, mutations, And the phenotypic analysis also proved that these viruses were as fit as any other HIV laboratory isolate. Isolates from some of these elite controllers have also been shown to replicate vigorously and cause depletion in humanized mice. On the other hand, we have the Sydney blood bank cohort, which comprises individuals who were infected by a blood transfusion from a single patient whose HIV-1 isolate contained large deletions in the NEF gene and the LTR. And all of the recipients became slow progressors or elite controllers. So indicating that some of these may have replication to incompetent virus. And we have other examples of this as well. Now, majority of these proviruses, we know that peripheral CD4 T cells in these subjects have small reservoirs with a low frequency of intact proviruses. Many of these intact proviruses are disproportionately integrated at sites which have limited transcriptional activity. And so this is why I'll explain it with a diagram because I think everyone is saturated. All right. So here you have the latently infected T cells which can undergo immune activation. Immune activation can lead to viral replication, an immune response and cell death, or they can undergo clonal expansion, where there's no expression of the viral antigens and there's this sort of enriched latent reservoir that exists. What happens to that reservoir? The provirus is integrated inside either transcriptionally active cells, wherein again the latency may be reversed at some point. There would be viral proliferation, T cell response, and cell death, or they may remain transcriptionally inactive for prolonged periods of time. And these expansion of activated sort of T cells, which are not transcribed, leads to this enrichment of cells that harbor proviruses that are in a state of deep latency and thus do not express any viral protein. And finally, we do know, as per whatever guidelines we have, that despite all this, there is some degree of replication that goes on in these people. ART is strongly recommended for controllers if they have evidence of HIV disease progression in the form of declining CD4 counts or HIV-related complications. And even elite controllers with normal CD4 counts will show evidence of abnormally high immune activation, atherosclerotic markers, and increased risk of non-AIDS related diseases. So DHSS guidelines repeatedly have mentioned that these patients should be offered ART. And finally, there are enough reports of elite controllers transiently or permanently losing control of viral replication and becoming viral. So this patient, in the course of all this, while he was still procrastinating over his ART, developed painless lesions on the penis. He was started on ceftriaxone for 14 days. You remember his his TPHA-VDR were positive. His genotype resistance assay was advised, it was not done. He was started on DTG, TAF and FTC. And you can see this was his RPR titer in 2019, slowly coming down 2020, but remains here at grumbling at 1:80 even 2 or 3 years later. He's had no new genital lesions over the past 2 years, no rash, lymphadenopathy, he's remained absolutely well. He's only gained excessive weight because of the ART claims and he's going for a liposuction procedure now. He continues to have unprotected sex with multiple partners very often. So his titers are declining, it's less than 4-fold, but it's been 2 years, should we wait? Retreatment, is it an option? And what would we choose this time? What about the possibility of reinfections in a patient like this who continues to have, multiple partners and will not use protection, etc. So first, and as sir pointed out, in the HIV population, these may disintegrate slowly or not.
Why did we use ceftriaxone and not benzathine penicillin in this patient?
So again,
yeah, because that is
again, because we always treated patients with latent syphilis as neurosyphilis, we've always given them ceftriaxone.
Yeah, because this patient does not have any CNS manifestations. He has, genital lesions. So he's the patient who should be treated with benzathine penicillin.
And he is somebody who received penicillin earlier as well.
But that was when he was 15 years old.
15 years old. So again, making us wonder whether this is a recurrence of primary syphilis,
Or
But even if it's a recurrence of that syphilis or it's a new infection, this
I agree
is,
with you. That
yeah, so I mean, for this kind of patient, your first treatment should be with penicillin. You would give 3 doses, and that is fairly easily available because we give it. So, I mean, for this kind of patient, the earlier patient, I agree we should give ceftriaxone because there's an issue of CNS penetration. Now, this patient does not satisfy the criteria to assess for CNS disease in any way because he doesn't have any of those findings like ocular, otosyphilis, cranial nerve dysfunction. So I think we should, I mean, that is the first line therapy, so we should have treated him with this. But if now only his titers are not declining further and he doesn't have any clinical symptoms, there is no need for retreatment.
Dr. Kulkarni.
Sorry.
Questions, all these 3 questions. One thing is that we have to keep on doing titers, especially seropositive, or for that matter, all patients with syphilis who are treated. We usually take it as declining titer or even a steady titer as a proof of treatment, successful treatment. So there could be some people who would be seropos, the titers may just remain the same. Because it's a kind of a mechanical test, so 1 stage down, 1 into 2, 1 in 4, we generally don't take it as significant. It has to be 2 steps up. So that's why we are saying 4-fold down or 4-fold up. But even if it is holding, it should be taken as a proof of
remains static.
static. It doesn't matter. TPHA is never going to be negative. Yeah, so it is just going to remain same or there could be declining titers. If it is so, take it as a proof of treatment, complete treatment. Rising titers tell 2 things. One thing is reinfection because it doesn't protect from the next infection. So someone with repeated unprotected sex is going to have chances of reinfection and you have to treat it like that. So whether it is
How often would you check it? Every 6 months? How often? Would you check?
if the person is so high risk, I would at least screen every 6 months. Unless the person is coming to you every time. But I would say that you should keep on coming. But what I follow is first test after 3 months to see how it is going. Then every 6 months for 2 years. If it's still going down, maybe once in a year after that. That is what I follow. It's nothing to do with the textbook or something. That's one thing. Second thing is reinfection is always possible. And third thing is retreatment is always possible. Just because someone was treated with something else in the past and has got reinfected, because rising titers tell 2 things. One is incomplete treatment, but if you are sure that the treatment was complete, then it is reinfection. And in both cases, you have to go back to the complete regime.
In this case, sir, the RPR, the VDRL titers, they are reducing. Basically, if he has an exposure with someone else, how likely is he to transmit the disease to the other person? The RPR, VDRL, so the VDRL and TPHA both are positive. The titers are reducing. So do we say that the patient is already treated and he's unlikely to transmit it to his partner?
We just don't know because whether he is actively infected right now. If
The
someone,
titers
no.
The titers don't correlate with the infection.
Yeah. Now see, previous infection, your titer has remained steady or gone down. But 2 weeks back, you have got a reinfection or a re-exposure. Now you are infected, irrespective of this titer. So in this kind of a person who is very highly, as you said, prolific, it's very difficult to say anything, and you have to say that you have to have protected sex because your penicillins and titers are immaterial. It's only a person who is having sex, who has been treated, whose titers are coming down. You are reasonably sure through your counseling that there is not much exposure, then you can say that you are not infective or something. But otherwise, this kind of a patient is impossible.
And also the VDRL rises late. That is why it is not sensitive in primary syphilis. Your VDRL titer starts rising late. So you cannot say that he is non-infective if his titer has not risen. But I mean, right now, we are more interested in his benefit. Our first objective is his well-being. That would be the first thing. So I think if his titer is static, you don't need to retreat him, but you would constantly monitor him. And if you see rising titers, it could mean reinfection. Another question which I had about the previous case was how soon did his vitritis and endocyclitis get better? Because our experience is that it takes a very long time.
So I think it took about 2 to 3 months, if I recall correctly.
Yeah, so we had one patient in which it went on for a year despite the fact that we treated him and then we retreated him with doxycycline.
Required steroids
and other things.
but he responded well. And this is a paper showing us that in individuals with previous syphilis, they are actually more likely to be asymptomatic when they are reinfected. So the degree of, early latent or late latent manifesting in subsequent episodes increases. And even their, detection of treponema, either by rRNA and the CSF also was significantly lower. And as Sir pointed out, immune dysregulation associated with HIV may actually result in a slower decline and greater fluctuation of the RPR titers. And this may actually lead to an increased probability of false positive diagnosis. But in a patient like this, it's very difficult to say false positive.
Okay. One point about your elite controller thing. So recently there have been 3 cases of being cured of HIV. And 2 of those cases, basically all of them have undergone the transplant and everything, and 2 of them actually had a CCR5 deficient that particular thing. Is it possible that one of the theories for an elite controller can be a CCR5 deficient in that particular individual itself?
They found a lot of sort of elite controllers who have what we call, for various reasons, the replication incompetent virus.
The replication incompetent virus is one thing.
You're
I'm
saying
talking
a
about the
CCR5.
host. I'm talking about the host.
But isn't this concept of elite controller or whatever is irrelevant when you say you test and treat? Because at the time of diagnosis, you don't know whether someone is late control or whatever. So it is now become irrelevant. Previously it was, okay, someone is elite controller, we don't want treatment for 15 years, 20 years or something. Right now when we diagnose, we put on treatment, we don't do anything. So
Well, not as often, sir, but I often have, not so uncommonly also, I have patients who have been diagnosed years ago and who come now,
I completely agree. I have seen someone who gave birth to a daughter who is also infected in 87 right now. And she became, so if she had come 10 years back, I would have said we will wait for that. But right now, if she comes, I am not bothered whether she is elite controller or not. I am just going to put her on treatment.
It's just an interesting
No, absolutely agree. So my question is that in these kind of individuals, should we further test those individuals for this particular mutation, whether that can be helpful for future?
But there's so many different reasons for it. I don't know whether
Yeah.
this would be.
Instead of putting for something future, is like saving your stem cells for future. Just put the patient on treatment and forget about it.
Okay. So I think I'll stop here. Thank you.
Thank you, Dr. Sunana. Thank you, all the panelists. This was an excellent panel discussion. And since we're running late, we're going to jump to the quiz now. And I'd like to call Dr. Bharat Purandare as our quiz master, consultant infectious diseases at Neonatal Hospital. Since we're running late, no arguments with the quiz master are allowed.
Okay, thank you. But Sujata, you wait here because you are also quiz master. So, do we have sheets given to them? We have prepared answers. Is it given to them? Or you can just pull a pen and paper and say round 1, 1, 2, 3, 4, 5. You have around 20 questions. And all are requested to attempt.
Very attractive prizes.
Very attractive prizes have been given. So I thank Emcure, I thank our prize sponsors, which are Genome Biotechnology, for sponsoring the quiz, and I thank Dr. Soman for giving me an opportunity to conduct a quiz. So do we have the quiz questions ready? So the quiz name is Kaun Banega CD4 Pati. So at the outset, let me quickly, I'll come down because you can see the question then. So are you able to see all of you? Some people who are sitting in this corner, they won't be able to see properly questions. So
They're
maybe
sitting
shift.
with a purpose.
Later on, I don't want complaint that we could not see fourth option and something. So all our fellows, I think our clinical pharmacists also there. Few of our medical students are there, medicine students. So please be ready, and all the consultants and my seniors, juniors, please be ready. So I've got 4 rounds. We have got 5 questions each, so 20 questions are there. So this I think I had put the cell phones off and the aeroplane mode on. If somebody is seen sneaking into the phone, disqualification will happen. Then so first round is relatively simple questions. So it should be easy cake for you. 1 mark per question. Okay. 5 questions of that kind. Then second round we have got funny questions which will test your wits. So it won't be like a answer. It could be a line of answer. It could be 2 lines. It could be an essay. But you will get only 1 minute for it. Okay. So it's not going to be MCQ type of question in round 2. It is like you have to think out of the box to answer those questions. Then third round is slight difficulty level is increased difficulty level, and so 5 questions of that kind, and last round will be negative marking. So in that round, if you miss the question, you will have -1 mark. Okay, so you have to be worried about the 4th round because you can really lose whatever you got in first 3 rounds.
And because we are short of time, there are no disputes allowed. So of course that part's gone.
All right. So has everybody got paper, pen ready? Okay. So let's start with the basic round. So first write your name on the paper and write your telephone number so that we can trace you. If we find that the prize is wrongly given, we can call you and take it back. So write down your name on that paper and write down your mobile number and start with this first question. So say round 1, question 1, and then you write one of these ABCD.
What is the signature of mutation associated with TDF? M184V, K65R, K103N, or M41N? Since
So
we're short of time,
nobody should say loudly anything. Huh? Okay.
Otherwise, you forfeit the prize.
You can say the wrong answer loud.
Okay, I'll move to round the question 2. Okay. Origin of HIV-2 is hypothesized to be from A. East Africa, North Africa, South Africa, or West Africa. Either you know it or you don't. So then I'll move fast to the next question. Okay. Now question 3. All of the following medications have low genetic barrier to resistance except A. Efavirenz, B. Nevirapine, C. Lamivudine, or D. Dolutegravir.
Easy? Is it easy?
Okay. Question 4. All of the following are almost always reactivation diseases except cerebral toxo, pulmonary tuberculosis, CMV retinitis, or PCP. Shall I go to the next? And the last question of this round is drug of choice for PCP prophylaxis in a sulfa-allergic patient is Dapsone, clindamycin, azithromycin, or darunavir.
So was that first round easy? Yes, students and fellows?
So you take the
Okay. So this round is funny, witty, and you have to think out of the box as I told you. The answer may not be what you may think. It may be different. And it could be a line or it could be an essay. So it's not a multiple choice question. So what is the similarity between an anatomy dissection manual and causative agent of PML? So if you could enlarge the book, then you could easily get the answer, but deliberately I have not enlarged the book's name. So you have to write down a line saying what is the similarity. Let's go to the next question. Time is enough? All right. So what is the relationship between these three pictures that you are going to see? So the first picture, I am not very sure whether you can see the names, but there are two scientists over there, and these two scientists' names I have given so that it's a clue for you. Second one is showing some African country, and the third one is showing a very aggressive kind of lymphoma Burkitt. So what is the relationship between three? It should be easy cake, is it? So you have to write down one line explaining what is the relationship between the three. Go to the next one. So which of the following cartoons or the things which are shown in that cartoon plays a major role in stopping the conversion of bradyzoids of toxoplasma into tachyzoids? Is it the CD4 cells, or is it the bomb of sulfadiazine, or is it this cute tablet of pyrimethamine, or is it Lord Ganesha? Okay, next question. This is going to be slightly difficult now. All right. So what can be a problem during treatment of cryptococcal meningitis, but essential to make a doctor successful in practice? Think out of the box. It's way out of the box. So that particular thing which we are talking about is a problem during treatment of cryptococcal meningitis, but the same thing becomes a virtue when you are a successful, busy practicing doctor.
Especially when you don't even know this.
So it could be one word or one line. So yeah, next question. So young man presented with these lesions. These skin lesions are red violaceous lesions. And the clue to the diagnosis of these lesions is A, history of exposure to cats. B, history of exposure to body lice. C, the picture of the ear lobule. And D, all of the above. So this is just one liner, A, B, C or D. Round 2 is over. Yeah. Shall we move to the next round? Okay, so some tough questions coming your way. So will you read, Sujata? Yeah, go ahead.
I think the negative one.
Okay, all right. So I'll read this round. So question 1 of round 3. The HIV drug resistance testing is best performed A, at any point of time, B, while the patient is on failing regimen, C, after 4 weeks have passed after stopping the failing regimen, and D, now I don't believe in resistance testing.
Be one answer.
Of course. Yeah, I mean there could be more answers, but choose the best possible one. All right, next question. So this is a 39-year-old male who's treated elsewhere for weight loss and loose motions, and he was admitted to ICU and he was being treated, and he also had oral candidiasis which was also being treated. You can see that the chest imaging has shown a miliary TB as well as the big nodule over there. He was given HRZD, levoflox and steroids. So after starting this, he improved over a period of 1 month, but he developed a right upper limb weakness over 15 days, and his weakness progressively worsened along with headaches and drowsiness, and he had to be readmitted back to the ICU. And this was the MRI, which showed a lesion over there. Can you see the lesion in the MRI? Alright, so the treating team thought that this could be MDR TB, and he was started with this second line regimen, Moxie and other drugs. And he was referred to the infectious disease specialty for opinion. He was found to be HIV positive, CD4 was 23, viral load was 2,35,000. A fresh chest X-ray showed a near complete resolution of his earlier biliary nodules. So this is the CNS lesion again. To recapitulate, what do you think is the likely etiology of his cerebral lesion? A. Resistant TB. B. Paradoxical response to TB. C. Nocardia. And D. None of the above. So want to go back to previous slide. So these lung nodules had resolved after giving HRZD, but a new lesion developed in the CNS which caused him hemiparesis. And now we are asking what is the cause of this new cerebral lesion while the patient is on ATT. A. Resistant TB, B. Paradoxical reaction, C. Nocardia, D. None of the above. Go to the next question. So this was a 49-year-old HIV positive person with a baseline viral load of baseline CD4 of 150. Viral load is not available, and he was on TDF, FTC, EFV. He was claiming a full adherence for nearly 18 months. And after that period of time, he came with a weight loss of 12 kg, CD4 falling to 15 with a suppressed viral load. And a large palatal swelling, I don't know whether you can appreciate, but it was a huge palatal swelling which was obstructing his respiration, swallowing to the tune that you could hear his breathing loud, standing at 5 feet distance from him. Stridor was there, he had carotid swellings as well, a nasopharyngeal mass and a significant hepatosplenomegaly. So, from this history, what do you think? What is most likely? A. Kaposi, B. NHL, C. Histoplasmosis, and D. Any of the above. So please choose the most appropriate one. Go to the next question. So, a 70-year-old, both HIV-1 and HIV-2 positive lady, she presented with a prolonged severe diarrhea. It was watery, non-sticky, and this stool sample showed these organisms on a spatial stain. Can you see the organisms? So what do you think amongst these options is most likely to eradicate this infection? So, will A. nitazoxanide eradicate this? B. Aromomycin, C. TDF-FTC, EFV, and D. TDF-FTC, LPVR. So, my question is, what will eradicate the infection? That's the clue. You got it? Okay. It would have been very. Now, last question of this round, 3. So you can see these extensive lesions in a 17-year-old HIV infected individual. So I'm not going to describe the lesions, it is very apparent from the lesion, what kind of lesion it is. So it can be caused by all of the following except Cryptococcus neoformans, human papillomavirus, molluscum contagiosum, and Taloromyces marniaceae. Easy? Alright, let's go to the last round now. Negative marking. So Sujata, please take this round.
What is true about K65R? It compromises TDF, ABC, and DDI. B, it increases replicative capacity. C, it increases susceptibility to NNRTI. D, it induces hypersusceptibility to 3TC. I think we should have put this in hardcore HIV. Okay, next question. Now take a deep breath, visualize Pujari sir, and match the study to the ARV. Okay, so we have Namsal, Dawning, Title, and Discover, and then you have the ARVs on the right.
So you can come this side.
Pujari sir is not here, no?
No, he would take away the prize.
No, you would have found that a problem with the options or something. No, this is the.
So you would have said dawning B and something like that.
Dawning at 96 weeks and dawning at 48 weeks.
All right, just give them 1 minute.
Yeah,
for
this has to decide. It took me time to make the slide itself.
See, one strategy was discussed. So
two were discussed.
Two were discussed. I think Titan and Dawning.
Discover. Oops. So now I'll have to go fast. Okay, are we done with this? Can I go to the next question? This is a okay. This is an HIV positive patient with a CD4 count of 20 who presents with fever and this lung lesion. The differential diagnoses are all except TB, nocardia, Rhodococcus equi, or an invasive mold. You can see this nice cavitating lung lesion. Okay? I go to the next question.
Yes.
Which is the correct combination of rifamycins and ARV regimen? A. Rifabutin 300 mg OD plus a PI. B. Rifampicin 600 mg plus dolutegravir. Rifabutin 300 mg OD plus dolutegravir. Or rifampicin 600 mg OD plus bictegravir. Which is the correct combination? Sorry, option B is rifampicin 600 mg OD plus dolutegravir.
I think our clinical pharmacist should get this.
And she won't write her name and her contact number if you put so much pressure. Okay, next question. We come to the last question. You all need more time on this time. Okay, iris correlates best with. So this choose the best option out of all of these. A. Increase in CD4 count after initiation of ART. B. Degree of viral suppression after initiation of ART. C. HIV viral load prior to initiation of ART. Or D. The duration of HIV disease prior to diagnosis. Please choose the best one.
At the last. So done, everyone has attempted all the questions. I hope all of them have attended round 4. So to decrease our work, can I request you to exchange the papers so that you be the checklist of the other one?
And not have a mutual understanding
But the
about
last round will require marking in a different way because if it is wrong, it will be minus. Okay, so don't be generous.
If it is unattempted, then
If you have left unattempted, it is 0 for all 5 questions. Can still be a good bet.
So now I'll start with the answers.
Alright, so should we disclose the answer? Paper exchange has been done, somebody is not getting a partner to check the paper. Give your paper. Prizes cannot be exchanged, only papers can be exchanged.
Prizes can't be shared either, so no mutual understanding in the marking also.
Hey, can I request to correct this? Alright, so your question answers are
Because they can't argue with you.
okay, alright. So the signature mutation is TDF, it is K65, so answer is B for this round 1 question, and answer is B. Next, it is West Africa, so it is D. HIV 2, West Africa, Senegal basically. Senegal was the country where it was first. Question 3, genetic barrier. Obviously, dolutegravir doesn't have low genetic barrier, so answer will be D for question 3. And question 4, so it is PCP because everything else is reactivation. Toxo is reactivation, TB is reactivation, and somebody would say that even PCP can be reactivation occasionally, but I mean, if you want to choose the best one, I'll go with B. CM is obviously a reactivation. So question 4, answer D. Question 5 of round 1, it is Dapsone, drug of choice for PCP prophylaxis in sulfa. That is Dapsone. So they do tolerate it well. Nearly half of them will tolerate it well. So don't worry about sulfa allergy. Try them, Dapsone. So it is A. So it is B, D, 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 A. So you can sum up the marks of the first round for your fellow partner. Let's go to round 2. So of course it is Cunningham is the common answer, but I want the full answer. The full answer, what does JC stand for? John Cunningham. So John Cunningham was who? Was the patient. Of course, he was the patient in whom KML was first diagnosed. So you should write John Cunningham to get full answer. No, but the Cunningham manner is not John Cunningham, but similar it is Cunningham, but the answer should contain John Cunningham because JC stands for John Cunningham. So the answer which has come to mention the name John Cunningham, then it is the correct answer. Only Cunningham is a wrong answer, but there is no negative marking. Next. So was it easy? It was not easy. It is Anthony Epstein-Barr virus. So these are the ones who actually diagnosed Epstein-Barr virus in patients who were Ugandan children with Burkitt's lymphoma. That Dennis Parson Burkitt was a surgeon, was a missionary surgeon who was visiting Uganda, and he used to send samples every week to Britain. And after many attempts, these two people, Anthony Epstein and Yvonne Barr, to isolate actually Epstein-Barr. So the relationship is Epstein-Barr virus. So the answer which is coming to you should write Epstein-Barr virus. That is the relationship. So this was easy. So it is nothing but only CD4 cells. There is no drug which can kill actually bradyzoids. What you see actually Toxoplasma aeruginosus is nothing but damage done by the tachyzoids. So all the drugs which are given for Toxoplasma will kill tachyzoids. There is no drug which can kill bradyzoids. CD4 cells are the ones which will keep bradyzoids at bay. They will not convert into tachyzoids. So the answer is CD4 cells. So anybody got this? Headache? So headache cannot be a problem. How can it make a doctor successful in practice? Please ICP? What is that? How many use fountain pen nowadays? Iris. So yes, somebody nearby. Very close. So answer is actually paradoxical response or paradoxical reaction. So when yes, so it is nothing but iris. So And it can also be translated for a public relation.
PR. Basically, PR is the problem during treatment of cryptococcal meningitis. PR stands for paradoxical response for cryptococcal meningitis. And PR is public relations for a successful doctor practice. We are running late of time, so no arguments with the quiz master.
So I think if anybody has got it, it will be great. Yeah. Iris cannot be expected. It has to be PR.
Okay, next.
All right. So the answer to this question is.
You should give separate prize for this question if someone has given.
So that was to Dr. Soman only.
See, it is easy to devise a question. It is more difficult to get the answer.
All right. So the answer to this question, the last question of round 2, is the picture of the ear lobule. That is C. C is the answer because anybody can tell? Shweta? Huh? That ring, black ring? Yeah, so basically it is an old concept. For around 40 years back, there were socially active MSN groups who used to say that we are going to wear a particular ring to show asymmetry because they thought that they are asymmetrical. So asymmetrical jewelry. So they used to wear one ring in 1 year, and it was different in different continents. So it was like in the US they used to use left, and in the UK they used to wear in the right. But in the 1 year logo they used to wear a ring, the MSM population. So this patient nothing but this patient has HIV, this patient has Kapochi, and the clue to this is the ring which has worn because it is suggestive of his serostatus. Nowadays nobody does this, but it was done. And about why not answer A? Because cats is Bartonella Hensley and lice is Quintana. But this is not Bartonellosis, so this is Kapochi. So the answer is C. Round 3.
If any drug is testing is birth. So you need to answer.
Okay, this answer is B. While the patient is on failing regimen to catch those mutations, it is B. Once the patient finishes the drug and stops 4 weeks, it may not pick up the mutation. They will get archived. So of course, the answer D is also not that wrong, but the best answer is this B. Next question.
The biliary TB with
Yeah.
CNS lesion.
So answer is D actually. D, none of the above, because the brain lesion, if you can see, it is exactly the book picture of toxoplasma, where you can see the eccentric dot sign is there, and you can see that there is an irregular ring enhancement. So basically, this patient had both together, and because it was toxic, if it was resistant TB, the pulmonary lesions couldn't have regressed. And to say that it is a paradoxical response, ART was not started okay. And nocardia is actually rare in HIV, but if at all it is there, it can produce lung cavities. So CNS nocardiasis is somewhat rare. So the best answer will fit is actually none of them. So it is D. Then next, the answer to this is NHL. That is B. Because it could be easily confused with histoplasmosis, but by the time the histoplasma lesions become so big, they will start ulcerating. And this patient did not have ulcerated lesions, and again, sheer commonness, histoplasma is definitely rarer than NHL. So answer, the best fitting answer will be NHL. Next. So these are basically cryptosporidia. So nitazoxanide can temporarily suppress the diarrhea, but it cannot eradicate the infection. Answer is what will eradicate. So it is highly effective ART. And because this patient is HIV 1 and 2, you need to have a boosted PI. Even if it was dolutegravir, it was okay, but this doesn't contain dolutegravir. So the best option would be D. Because efavirenz, which is contained in option C, cannot cover for HIV. And the last question in this round is, this is nothing but pearly white classic umbilicated lesions of cutaneous cryptococcosis, but it can also be seen in molluscum and thalaromyces, but papilloma lesions are not like this. So answer is B. So for this round, the sequence will be B, D, B, D, B. B, D, B, D, B. Now negative marking round. So here now you have to If the answer is wrong, please give -1. So the answer for question number 1 is A. So true about case 65 is it compromises these 3 options, and B, C, D is not right. So when somebody has attempted A, he will get 1 mark, other will get either 0 or -1. Next. So here for first, that is Namsal,
It's
it
DTG
is
versus EFP 400.
It is low dose
D.
So non-inferiority, and so that is D. For 2 it is C, dawning. It is DTG with NRT or LPR with NRT, non-inferior. For 3 it is A, Titan. It is Darunavir, Ritonavir versus Lopinavir, Ritonavir, and for 4 it is B, TAF or PrEP. So 1D, 2C, 3A, 4B. That should be the. So if anybody is getting all these 4 correct, 1D, 2C, 3A, 4B, then we will get 1 mark. Otherwise 0 or -1.
One is better than -4.
Next. So this question is 3, no? 3.
All except.
Yeah, all answer is A. Because the TB generally at this low CD4 count generally will not cavitate, whereas rhodococcus can cavitate at any CD4 counts, and so also nocardia and mold. So generally TB will present at this count as a miliary lesion or something like that. So here answer is A. Then here answer is C. So rifabutin 300 plus DTG is the right combination, and everything else is not right. All right. And last question. Iris correlates best with B. Degree of viral suppression after initiation of ART. So answer will be B. So please now sum up the marks if you can, and we'll collect the papers. So best is with viral separation. Best is with viral separation, and that's why it is B. So can we have the answer sheets now here? We have a tiebreaker question.
So has anyone got 20 on 20?
Anybody with 20 marks?
90.
15 to 20.
80.
10 to 15.
Let them answer here.
Oh, very good. 10 to 15, we have got 2-3 hands of show of hands.
Okay, so what are your marks? 11. And
10.
So only, is there anyone above 11?
Anything up? Anyone above 11?
So now for the one
We have got a tiebreaker question.
Okay.
Wait. Let's first have this. 11, 3. Okay. How many are 11? 1, 2. There's a tiebreaker between them, no? So 11 is the maximum. Anybody is in minus? Chalo, so please can you come forward who has got 11? So sit here. And who's got 10? You have got 10. So please come forward. So we have got 2 people with 11 and 1 person with 10. You have got 1 more person with 10?
No.
10. So 3 persons with 11. Huh? So please come in front. So, so there will be. So 3 people with 11 will go for a tiebreaker. So the one who raises the hand first.
Yes, sir. Fastest fingers.
हमें tiebreaker करना है.
So now it's fastest fingers.
So ऐसे ही आप आगे आके बैठो क्योंकि दिख रहा है question बार. Because then you will have to see the question properly. All the questions. All right, so we'll have a tiebreaker for. So negative mark is there. Only one question for tiebreaker. जो हाथ पहले उठाएगा उसमें करेक्ट आंसर देना चाहिए नहीं तो नेगेटिव मार्क को प्राइस के इसमें से बाहर जाएगा.
Okay. Recent news declared a third person cured of HIV. The patient received HIV-resistant stem cell transplant, haplocord blood transplant, unmatched allo-HSCT, or none of the above.
Pass.
We have only one.
all one.
Otherwise, the quiz masters get to pick.
No, see, we have got 3 prizes and there are 3 people, isn't it? So we have to choose one of them because other one would get prize number 1, prize number 3.
So much for you decide some question.
No. So then the tiebreaker can happen as who got the negative marks in round 4. Come.
I got 1 negative.
You got 1 negative? How many negative? How many negative?
I got 2 negatives.
2 negatives. And you? 2 negatives. So I think you get the prize number 1.
And then the tiebreakers between both of them.
That is big no, so they will give them what a prize. Chalo, so let us invite the prize the winners on stage.
This answer was haplocord blood transplant.
Sir, please come, sir. Please introduce yourself.
I am Dr. Manoj from Vaginal.
Manoj Shevai. Who got more negatives amongst you? 2 and you got? So there will be two prizes. So there is nothing like 2 and 3. All right. Joint winners. Congratulations. Dr. Karthik. Congratulations. You got 11? But then you did not come up when I was calling how many has got 11. Okay, we'll give you a consolation prize later. What is your name?
My favorite.
And Dr. Sir doing fellowship at the Dr. Sir.
We'll get right now only big round of Very good. So congratulations to all who have won and congratulations to all who have not won.
Very good, sir.
So thank you all. We conclude with day 1 of Updated HIV and we will be starting at 9:30 AM tomorrow. So see you all there. Thank you.